let them deeply. Yes. We try to
So I'm just supposed to give the. Yeah. Wait, I'll just ask you.
I think we should also talk about it.
Yeah.
I think from a self.
So it transforms that into like women's agency and rights, so like those are being activated.
That's really nice.
Yes, go for it.
What is actually focusing on
I just want to give them some
वैष्णो के लिए
yeah, well, you no idea how much work you did.
I not find people pictures and this person enough to go.
No, I'm all over. Wow. Okay. Well, you currently about Dubai.
But we still can structure pipeline. So ये सब this is where Astra
still focusing
really needs
space. I do see like anytime I go to a public
You can take any sticker, any two, and postcards.
That's nice.
अच्छा रहेगा.
एक्सपीरियंस के बाद
Someone please come. Can I have
Awesome. What are you calling it?
what's the name? My
It's called
sorry.
Hunger and Desire. So it's very
It's done. It's for now. It's just for America.
Thank you so much. No, I have no.
Ma'am, you can take any of the tips.
So this is for the fourth agenda for now, and I think this is right now the agenda.
If you just can close your eyes and think, at the age of 18, which state were you in? Which state? Yeah, geographically, which state? Not mental state. Like Delhi, Bombay, Maharashtra, sorry. Which state were you in? Okay, how many of you were in Delhi? Great. How many of you were out of Delhi? Can you name some states? Where are you from? Okay. Okay. Amazing. Any other states we are missing? UP, Bihar, Jharkhand. Okay. Rajasthan we got. Kerala. Great. Uttarakhand. Nice. So there is a reason I asked this question. Before we go into welcoming you all, I wanted to ask a few more questions. When you were at the age of 18, actually before that, did you know how many cycles were there in the menstruation or period? If you knew, please raise your hand. How many phases or cycles, what exactly the cycle means, a menstrual cycle means? Okay, I get one hand. How many of you knew that there is a fertility window within that menstrual cycle? At the age of 18 or before that? Okay, interesting. And how many of you knew that using contraceptives can delay or prepone your menstrual cycles? Interesting. So I hope these questions made you realize that menstrual health may be a missed opportunity within the larger sexual and reproductive health umbrella. Now, if you just look around, you will see researchers, policymakers, advocates, funders, and young leaders. Every single person here has in some format worked on menstrual health, as well as in some format worked on sexual and reproductive health. Maybe some of you have worked in both the aspects, and yet the two of you almost never were in the same room before. Not really, not in the sense that it actually matters. Not in policy, not in financing, not in how we design the services, the programs, and the systems that we deliver. That is the challenge we are trying to address here today. Over the last decade, we have made real progress. Awareness has grown, products have become accessible, and conversations that were earlier in whispers are now in conference rooms. That progress is definitely real and it matters a lot. But here is what that has not changed. Menstrual health is still largely treated as a hygiene issue. School program, product distribution drive, while right next to it, sexual and reproductive health systems are dealing with contraception, family planning, bodily autonomy, maternal health. These two worlds share the same starting point and the same people. Yet, what remains unmeasured remains unaddressed, and what remains unaddressed is the missing indicator we are trying to talk about today. Now, over the last 8 years, Bala has worked with over 1.5 million women and girls across the country as well as in some other countries, from the aspirational districts of Meghalaya and Jharkhand to the urban slums of Delhi NCR and Bombay, from the factories in Karnataka and West Bengal to the sports fields of Maharashtra and Himachal, from the mining affected communities of Odisha and Chhattisgarh to the flood prone areas of Bihar and Assam, from the caste segregated communities of Tamil Nadu and Madhya Pradesh to the mountain and remote regions of Nagaland and Jammu Kashmir. In all these workshops, sessions, and evaluations, we have repeatedly seen some patterns. A girl who had not got her period for 3 months and did not know where to go. A woman who quietly stopped taking her contraceptives because no one told her that this is going to mess with her periods. A teenager in unbearable pain every single month accepted it as normal. Now, these are not hygiene gaps, these are healthcare gaps, and they exist because menstrual health has been placed in one corner and sexual and reproductive health is in the another corner. While the individual is trying to make sense of both of these at the same time, that space in between is what we are calling the missing indicator. On 14th of May this year, Bala brought together global experts for an online panel to discuss exactly this topic. The conversation was sharp and honest and uncomfortable in the best way. Dr. Ankita will take you through that, and I will not get ahead of her, but what I will say is definitely this. Today is not about discussing the challenge again. Today is about moving past it. We have 2 panels, 3 learning sessions, and a room full of people who between them hold the knowledge, the networks, and the commitment to make that integration successful. All we need to do today is to be honest, be specific, and be willing to ask harder questions. Not just whether menstrual health belongs in SRHR, but what will it concretely take in policy, in financing, in service delivery, and in monitoring to make that a reality. Before I close and hand over to Dr. Ankita, a few quick house rules for the day. 1, if you need any help, please reach out to anyone wearing this Bala Boss badge. Kindly keep your phones silent. Avoid interrupting when a panelist or a participant is speaking and respect the speaker. And please try to minimize movement during the panels. Most importantly, please remain curious and excited, and please ask a lot of questions. You will also find that the tote bags you have received has the agenda for the entire day, as well as some games and activities for you. And for anyone who may in need of biodegradable pads, they are available in the washroom, as well as you can get it from the registration desk. I am Subhojit from the Founder's Office at Bala. And on behalf of Soumya, Aradhana, and the entire Bala team, I welcome you to find that missing indicator together. Thank you so much for coming here. Now I would like to welcome Dr. Ankita, who is the Communications and Research Specialist at Bala, to set the context for the day. Thank you.
Good afternoon to everyone, and thank you, Shubhajit, for the wonderful introduction. I'm going to briefly take you through some of the context of why we are here today. Imagine a young girl during the baseline for a menstrual health program who revealed that she started menstruating at the age of 14. By 16, she was married, and today she sits in front of me. Didi, my in-laws have been telling me that I will now have to start a family. I don't understand what that means. They say I will soon understand. This and many more stories made us take a step back in the work we were doing in our programs, where we addressed menstrual hygiene, pain management, nutrition, tracking, and myths. But in our work in all these years, these patterns kept emerging, and so in 2024, we decided to broaden the scope of work to include sexual and reproductive health, because they're mostly understood in isolation. In 2021, UNFPA had published a technical brief on the interaction of menstrual health into sexual and reproductive health and rights, policies, and programs. The document highlighted 13 intersectional areas that placed menstrual health at the heart of sexual and reproductive health. In 2022, the UNFPA, along with WaterAid India and MHAI, authored another report on integrating menstrual health and sexual and reproductive health and rights, highlighting the insights from and implications for India. The document further spoke of the intimate linkages between SRH and MH across the reproductive life cycle. Some noteworthy data points relevant for our understanding of these linkages included the lack of awareness about menarche and the source of menstrual blood, absence of knowledge about the menstrual cycle, the prevalence of anemia in general and among persons with heavy menstrual bleeding, contraceptive-induced menstrual bleeding challenges leading to a discontinuation of contraceptives, and prevalence of endometriosis and its impact on fertility. The recent Supreme Court ruling recognizing menstrual health as a fundamental right has larger implications for human rights too, as poor menstrual health infringes the right to health, education, work, non-discrimination, gender equity, water, and sanitation. This further highlights the need for integration of menstrual health as an important indicator in overall health programs, along with frameworks on rights and justice. Our work on this integration emerged from our own understanding of this need. A needs assessment in one of the communities helped us identify a point of integration. Our learnings highlighted the larger reproductive crisis faced in the community, with patterns of early childbearing due to early marriage, inability to plan families despite intent and contraceptive usage, and recurrent miscarriages. We further identified knowledge gaps associated with the menstrual cycle and the impact of disorders on fertility. As we worked more intently in corroborating these learnings into our programs, an interaction with a frontline worker in a remote village around East Singhbum area of Jharkhand strengthened our belief in the importance of integration. For the last 15 years, she had been using the knowledge of the fertile period in the menstrual cycle to help women plan their families in this community. The village, so far removed from basic infrastructure, including schools, hospitals, and even roads, boasted of families with a maximum of 2 children. We launched 2 programs in our communities focused on nutrition, menstrual health, family planning, and menopause. These reports are also available on your tables. And the results were remarkable. We found our participants feeling more confident, helping their peers and family members, and even talking to their partners about choice and agency with greater autonomy. This year, preceding Menstrual Hygiene Day, we organized an online panel, as Shubhajit already mentioned, on integrating menstrual health into sexual and reproductive health rights with experts in M&E, CIMBC, and human rights. The key learnings from the panel highlighted how framing menstruation solely as a personal hygiene issue shifts responsibility entirely onto individuals while obscuring systemic failures in healthcare, labor policy, sanitation infrastructure, and social support systems. The panelists stressed the need for integrating counseling, co-delivery of services, and shared monitoring systems across menstrual health and family planning programs. Examples from state-level implementations demonstrated that integrating topics such as menstruation, contraception, gender, safe abortion, and violence into a single framework improved educator confidence and created more open, non-judgmental learning spaces. The speakers further emphasized that menstrual health must be integrated into labor rights and social protection discourse rather than remaining confined to health and hygiene programming. A strong recommendation from the discussion was adopting a life course approach to menstrual health. The discussion also emphasized integrating nutrition, anemia prevention, menstrual disorders, and mental well-being into the menstrual health interventions. The session identified that menstrual stigma is both an under-recognized and under-measured indicator within national systems. The conversation strongly advocated for intentionally including boys and men in menstrual health education and beginning dialogue from an early age. With these learnings, we are here today because we first-handedly see how menstrual health can be both a determinant and an outcome of sexual and reproductive health rights. We are here because we see the urgent need to embed menstrual health into health policy, financing, service delivery, and monitoring systems. With this, I urge you to share your learnings and use this day to reflect on how we can take menstrual health into the larger frameworks of rights, justice, and equity. I would now like to open the event with our first panel, The Case for Integration, which will be moderated by Soumya Dobriwal, the co-founder of BALA. I invite Soumya on the stage to take the conversation ahead with our speakers. Thank you.
Good afternoon, everyone, and welcome to this very important discussion for all of us in the room. And it's extremely meaningful and personal for every one of us in the organization as well, because this is something we see every single day happening in the communities that we work with. So thank you for being a part of this, and we're so curious and interested to learn from all our panelists, but also all the participants in the room today. So my name is Soumya, and I'm the co-founder of Bala. When we started the organization 8 years ago, every single day, the work has taught me that menstrual health is not about a product. It's about systems and who holds powers in those systems, what gets spoken about, and what are the things that are just shrouded in stigma and hence never get prioritized. So today's panel asks, how do we move menstrual health from the margins to the mainstream? Not only in programs, but also in policies, data, and evidence. And how do we fund and design our systems? And who actually talks about all of these decisions? Who actually informs all of these decisions? But before we start, I want to introduce the extraordinary people on stage with me. Poonam Mutreja. Poonam is someone whose name is synonymous with 4 decades of very courageous work at the intersection of gender, public health, and policy across multiple roles. Currently, she's the executive director, amongst many other things, honestly, the executive director of the Population Foundation of India, and she shaped how our country thinks about women's health. So thank you very much for being here today. Dr. Ajay Khera. Dr. Ajay Khera is the country representative of Engender Health and a senior public health expert with decades of experience in reproductive health, adolescent health, and national public health programming. He possesses the very unique ability to hold both the systems perspective and the ground reality all at once. And we are so curious to learn from you, so thank you very much for being here. Tanya Mahajan is someone who's been doing the hard but very essential work of building a shared menstrual health ecosystem in India through research, policy engagement, and convening the right people. She's the co-founder of the Menstrual Health Action for Impact and brings 16 years of perspective spanning menstrual health, WASH, and sexual and reproductive health. Tanya, thank you for being here. So let's get started. I want to start with you, Poonam. My first question is something that's been coming up in our communities, but also in our panel a few weeks ago. Only 1/5 of girls that we work with actually knew about menstruation before starting their first period. And yet the bulk of menstrual health programming actually just focuses on product access to date and hygiene management. Even some of our colleagues from PFI noted that in the Family Health Survey 5, menstrual stigma remained an unrepresented indicator. So this tells us that the silent isn't just social, but it's not just being measured at all. You've worked for decades at the intersection of behavior change and gender equality. In your experience, why does the stigma and silence persist even as awareness campaigns are increasing and multiplying? And what would it take for the stigma to be treated not as a byproduct of the problem, but as the problem itself?
Thank you very much for having me here, and thank you very much for the work you do. And clearly, a lot, you've identified the missing indicator. You seem to be at the really cutting edge, ahead of the curve in your thinking as a group, from whatever little I heard, I was already very impressed, and I think we learn more than you will learn from us. And the fact that you've been focusing on this and raising issues which, you know, the so-called reproductive sexual health experts, and in the dialogues I go to, you know, in terms of not linking it to all the 15 indicators. UNFPA did this and put it out there, but it hasn't led to I mean, this is no criticism of UNFPA, but let me come to the example, question. See, first, let's acknowledge this is only a women's issue, a girl's, they experience, so not issue. Girls and women experience menstruation. Men don't. So the men are not thinking about it at all. And given the culture of silence around menstruation based on many, you know, first of all, anything that is considered sort of in the realm of untouchable gets completely, it has for years and generations, we didn't talk about. And I will share with you how actually menstrual, I mean, products and issues came on the agenda in terms of little bit on the health ministry. So one is, there is an untouchability aspect. You all must know that even today there are large number of women who have to sleep in the cow shed or outside, cannot sleep in the same room as the family or in the house. That's one extreme. But whether it's pujas, our country is full of pujas and increasing. So, so girls and women who are menstruating, there is so many, every day is a puja, every day is some god's day, you know. So then again, women are considered impure. There's untouchability, there's impurity. And then there is, of course, we'll have a Kamakhya temple to say, ha, hum bhi kuch samajhte hain. But overall, it's all these, let's go to social norms first. And that is something, even pickle, you know, a menstruating girl is not allowed to put pickle, kharab ho jayega. I mean, I'd love for someone to prove that scientifically. But anyway, there's enough in India where we, based on myths and misconceptions, we continue to ride high. So, pun intended. I have to say that even today, while we're using the word stigma, but what are we doing about women not sleeping in sheds? What are we doing about women doing puja, participating in puja, even when there is, because, you know, those are the larger issues. Then finally, the big secret, the big issue is that menstruation has a lot to do with sexuality, reproductive health, reproduction. We don't want young people to know about it, especially girls, you know. But what do people traditionally think even today, not just in the villages, but in communities where patriarchy is stronger than in some of our houses? Arey, she started her periods, let's stop feeding her milk. She started her periods, let's think of marriage. Let's think of the worrying about the security of the girl. They know, the parents and the community knows that now she can get pregnant. So let's get her married. That's a cause of early marriage. So menstruation, actually, you might like to redo a chart, the wonderful chart that UNFPA had done, where you put menstruation and then go to all the gender patriarchal issues around that. And ultimately, there is a fact that we want to hide from young girls. We want to hide the fact that now they can get pregnant. Nobody, even the UNICEF study where they did a meta-analysis of 138 studies, they found that only half the girls knew anything about, from little bits to more, about menstruation. They knew very little. And never is it linked to menarche, ever linked to the potential for getting pregnant. And that's why we have so much, not only teenage pregnancy, but we have so much, unfortunately, rapes where girls end up getting pregnant at age 13 and 14, and then the Supreme Courts take their time. We should thank Supreme Court for that great judgment on menstruation, but otherwise they take their time, and then we have panels to allow a 14-year-old, 10-year-old pregnant girl who's been raped from getting her. So look at everything. I mean, it's not one thing that leads to the stigma or the issues around this, and I think we really need to work on changing social norms and do behavior change. We will make progress like we've done in NFHS 6. So now close to 80% girls are using some form of menstrual, I won't say hygienic, but some form of protection. But also, you know, let's think of sanitary pads and I expect after a point we are going to have a backlash on sanitary pads unless we worry about disposal. Okay. And in fact, when the government of India decided to provide sanitary pads, which by the way came from a meeting a few of us had with Mrs. Gandhi at some point, Sonia Gandhi I'm referring to, who was absolutely shocked at what she heard. And she actually called the education secretary and health secretary the next day and said, let's do something about it. But it still took us many years to do something about it. When I was on the committee, Dr. Khera, I don't know if you were in Delhi, he was in the health ministry for a long time and a great supporter of women's health and our issues. I don't know if you were there when the National Rural Health Mission Steering Group set up an empowered group to bring in sanitary pads into free distribution of sanitary pads. And so I was on the committee that basically decided sanitary pads, but the high empowered group, my husband happened to be on that committee. And I said, I have to brief you. You have to take a good briefing for me before you go to the meeting. And I said, my husband is a feminist, works on women's health issues, gender issues. But I said, this you have to understand from me. So one of the things I said was, you know, we'll have a backlash. And if all women do start using sanitary pads, we have to think of incinerators. So bring that up in the government. Second, I said, you know, an uncomfortable sanitary pad. I told them about women don't have access to underwear. So just sanitary pad is not good enough. If they're going to tie a nada, you know, it's not going to help. But second, I said to him, the quality has to be good. It has to be subsidized and high quality. Because, and then what happens? They gave the contract to HLPPT, which made horrible pads. They had no experience in making pads. And I went for a field visit to Himachal, and I couldn't find my way into the primary healthcare center because there were mounds of sanitary pads returned by girls. So, you know, just even the product, we have to think of quality. Girls were getting allergies and so on. So just going back to it has to be behavior change, and it is linked to everything. By the way, I know I've spoken a lot, but my last comment, I funded a study in 1995 to look at the impact of unhygienic menstrual health, on STD, not STDs, not RTIs. And it was mind-blowing, you know. It was a small study in Kerala. So there is so much linked to it. So let's have it put at the center. Only then will we be able to even begin to challenge with the stigma.
I think, thank you for starting us off with giving us such a well-rounded perspective of it's about social norms, it's about product quality, it's about who's making the decisions, right? Like, are you taking that girl's opinion in the decision-making process? Like, how do we have a more integrated approach, not just in how we look at what is priority, but who's playing a part in those decision-making roles? So thank you for kicking us off with such a holistic perspective on menstrual health issues. Dr. Khera, you have worked across government systems and international health frameworks for many decades, and you've applied a systems thinking lens to public health challenges. When you look at India's existing sexual and reproductive health and rights in public health architecture, where do you see the biggest structural gaps? What is missing despite increasing visibility of the issue, according to you?
Very good afternoon to all of you, and thank you very much for inviting. So the question raised is, regarding the menstrual, health. And I'll be very frank with you, considering my experience of working in the government system for a long time, and particularly leading the Government of India's big program, which has been renamed number of times, which used to be called as the Reproductive and Child Health Program. Then it was called as the RMNCHA program, then RMNCHAN program. So number of names came. But if you truly look at this program, the focus of attention is it is a mortality centric. That means the objective of the whole intervention, the objective of the whole of the investment, because globally also you have SDGs, you used to have MDGs. Every time it used to be mortality centric. That means you need to demonstrate success in reducing maternal deaths and success in reducing the child deaths. That was the focus of attention. Now I think we have done, quite good. That's why I think this whole issue of SRH, actually within this complete RMNCHA framework, there is a one R which represents reproductive health. And I being very frank with you again, most of the people consider R as only family planning, and beyond family planning nobody understands. Now I am now working at Engender Health now for the last 5 years. I have started realizing the importance and the value of the sexual and reproductive health and rights. But when I was in the government system, the intent was maternal mortality, newborn mortality, and if this has to be reduced, we need to invest in family planning. I think that was the case made, and this is the way the case was presented to the government, and then the things move further, And now, as you know, that presently our TFRs are going down, and actually the R is being ignored without realizing that R does not mean only the family planning, it is beyond family planning actually. So that's why I think one of the challenge to my mind, and we as kind of a people with same thinking, we must position SRH as a complete package of intervention. I think people at the highest level are not very clear. What do they mean by SRH? They means SRH means a family planning, and our family planning job is done. So I think there is a real threat to my mind that whatever efforts we have made in the area of providing contraceptions, improving family planning coverages, improving choices, building the capacity of the people and the system. So I think it is the right opportune that we really need to position menstrual health as an integral part of the SRH. So as a step one, I think we need to make a strong strong advocacy that SRH is the need of the hour, and it is an investment which has to continue over a period of time. It is not like, it is like immunization. The new cohort of young people will keep coming, and they continue to need services. They continue to need information. You just can't ignore, R. So I think we need to really position, all those, we as an organization must position SRHR as a very critical component for improving the health of the population, health of the women and the girls. And second, the point is regarding the menstrual health. Whenever the word comes menstrual health, people think menstrual health is equal to menstrual hygiene. I think nobody thinks. I am so happy that, you have started thinking, and I being a gynecologist, I know that majority of the women who used to come to OPD, they have a menstrual issues. And particularly the so-called the women between the 15 to 45, the women who are menstruating, sometimes they have irregular periods, sometimes they have spotting, sometimes they have less period, sometimes they have excessive bleeding. Majority of the cases may not require intervention, but at least you need to provide right direction, right information. So I think, and if you look at the problem of the menstrual irregularities, which is called as the, people are using different words, people used to call it DUB, dysfunctional uterine bleeding. Then people started calling it, AMB, abnormal menstrual bleeding. Some people call it heavy menstrual bleeding. So basically it is a disorder of the menstrual, cycles, And I think the burden of this problem is so huge, to the tune of 30 to 40% women suffer from, abnormal uterine bleeding. So I think if the problem is so huge, I think it has to be positioned as a public health issue. I think nobody has made any efforts, and I'm so happy to note that actually you are bringing this issue of not as a menstrual hygiene, menstrual health as an issue, which is a public health problem. And this problem is so simple to be managed. And it is a problem which does not require equipments or big science. It only requires awareness. It requires little capacity of the healthcare providers, and even the capacity of the ASHA workers also. Because nobody talks about menstruation. As madam was saying, a lot of, kind of a stigma around talking around menstruation and so and so. So I think it's a right opportune that if we really want to position, menstrual health as an integral part of the primary health care, we also need to emphasize about this sexual and reproductive health and rights, SRHR. Make some, more clarification, clarity to the policy makers. We are not talking about immediate mortality reduction. We are talking about now it's a time that we should start talking about, India should start talking about, morbidity reduction. And if we really invest in this area, we should be able to reduce large number of morbidity, whether it is in the form of a RTI, or whether in the form of anemia, or whether in the form of, unnecessary visit of women and girls to various hospitals, They keep, moving from one doctor to another doctor, and for a problem which is normal actually. But somebody has to tell her that this is normal. So I think we need to do the capacity building of the healthcare provider. So the point is, I think, putting menstrual health as an integral part of the primary health care, and then also, clarifying what do you mean by SRHR. And to my mind, still many of the people, at least at the policy level, they are not very clear. We keep talking about SRHR, but people at that level, they are not very clear. So I think we need to come up with a very solid, kind of a advocacy to make people understand, what encompasses SRHR and what are the various elements and how simple it is to manage from a public health point of view. I think that's all from my side.
Oh, thank you so much. I think all of this, Dr. Kira, resonates so much because when we go on ground, even when people want to do good and want to invest in menstrual health programs, they'll keep providing sanitary napkins. So you will enter a village or a slum, वहाँ पर 5 अलग-अलग ब्रांड के सैनिटरी नैपकिन्स के कार्टन्स रखे हुए हैं क्योंकि उसके बियॉन्ड किसी को पता ही नहीं है करना हम हेल्प कैसे करें कम्युनिटी को क्योंकि दैट अवेयरनेस इज ऑल्सो कम्प्लीटली मिसिंग ऑन व्हाट दिस SRHR पैकेज नीड्स टू लुक लाइक बियॉन्ड प्रोवाइडिंग द सैनिटरी नैपकिन सो आई थिंक वीड बी सो कीन टू even work on thinking about what this SRHR package looks like and positioning it to other stakeholders including policymakers, decision makers, corporates, and everyone else in the system that's influencing women and girls' health on ground. But Tanya, I want to bring us to the Supreme Court judgment and the recognition of menstrual health as a matter of dignity and fundamental rights. But you know, we've seen menstrual health programming on adolescent girls in schools over the years and even in the judgment. But we wonder, what about people with disabilities? What about boys and men as allies? What about the full arc from menarche to menopause? What about navigating menstruation at the margins of the gender, at the gender spectrum? So what do you think we need to shift institutionally to actually embrace this broader vision of menstrual health?
Thanks for the question, Soumya, and for having me. I think as a response to this question, I would just say it all has to be a layer onto everything that Dr. Khera, you just mentioned. Because at the end of the day, if you look at the reproductive life cycle of a person, starting from, or even pre-menarche, not even starting at menarche, but pre-menarche, going up till menopause and beyond, all of these issues come into play in some form or another. When you have a young adolescent person, you have issues of, previously PCOS, now PMOS, you have endometriosis, which is increasingly becoming more and more, it's being diagnosed more now, not prevalent, I would say. You have issues of heavy menstrual bleeding because of various concerns, could be fibroids, could be other things. You have abnormal uterine bleeding. You have menstrual pain, which itself is an issue and should be looked at as is, and may have many root causes. But I think, as you said, the health system looks at people or girls and women in a very sort of siloed fashion, right? You have anemia targeting adolescent girls, and now pads. Pads does not solve the health issues related to menstrual health and the early opportunity we have of influencing the behaviors, attitudes, the knowledge around menstrual health. So we are losing that opportunity. Then we go to family planning straight away. That's the next interaction with a woman. And even within that, I think family planning is still very much an output-focused, if I'm not mistaken, an output-focused program. It's not really looking at the bidirectional engagement of how contraception influences the menstrual cycle, or how contraceptives can be used to manage menstrual pain and various menstrual disorders. There's a different role there for contraceptives, not just for family planning. Better information around menstrual health can improve the uptake of IFA tablets, can improve nutrition around anemia, and you have maternal health. So you have postnatal health, which is completely, again, it's an output-based spot identification and addressing of problems, and not really understanding where the issues are coming from. And then the whole life cycle post that is completely missed. Women are attaining menopause in India and in LMICs in general 10 years before their Western counterparts, anywhere around 40 to 50. And perimenopause starts now, I would say, anywhere between 35. And I am 39 and I'm experiencing like extreme symptoms of perimenopause. And even for me, it's been so difficult to access care, access the right kind of advice. Obviously anybody at the fringes would not be able to access that. So I think looking at perimenopause and the 10-year period where it affects, the proximity towards NCDs, whether it's cervical cancer or even bone health, heart health, and what one can do in terms of advice during that period. Mental health, anybody who's had a previous history of depression is much more likely to be prone to mental health issues during that period. All of these linkages currently are unaddressed, and that's because we don't look at the person's experiences from a life course perspective. We look at it from a program perspective. So we need to look at a person as somebody who's experiencing menstruation throughout their life course, and how they are affected during that life course is something that we need to layer onto it. And you brought up the issue of those are the fringes. Of course, even if we look at what is being done right now, even if it is pad distribution, I don't think current programs or current approaches take into account intersectionality with, what is the context, what is the identity of people that we are reaching, and how is that affecting their ability to access products. We are not even starting to talk about services yet because we haven't even identified the problem. But even where products are being provided, infrastructure is being provided, those questions are not really integrated into the approaches. It is possible to do so. You have caste, you have issues of, somebody who doesn't even have access to a toilet in a school compared to their counterpart. How are they going to, manage that during their menstruation? Access to water is inequitable in our communities. If you look at some of these contextual issues, you have now also the question of climate vulnerabilities. People who are living in settings which are more prone to floods, droughts, and other climate extremities. So all of these affect the ability of women to manage their menstruation. And so I don't think currently our programs and policies take into account these vulnerabilities. It's possible. It's not that it's not possible. So if you have a department looking at the distribution of pads. You also have departments looking at particularly vulnerable groups, which could be interacting. But that's, again, an ask of advocacy that we probably as a community haven't made. So I would say these two approaches, one looking at girls and women across the life course, and second looking at how can we integrate more intersectional, more of an intersectional lens, bringing in caste, bringing in class, bringing in geography, bringing in gender identities into the question, and roping in relevant district level, state level departments into the conversation around menstrual health. The last point on this is that menstrual health is nobody's baby. And that's why, constant advocacy for coordination across ministries so that all of this can come together is so important. Like if we only speak to adolescent health in Ministry of Health, it's not going to lead to this solution. We have to speak to the cervical cancer program. We have to speak to people working on family planning. We have to speak to people across. So yeah.
Now, I want to admit what you said wants to make us work harder. It makes us realize ki kitna kaam baki hai for us as an organization. But to that point also, when we go to a ministry, like we'll go to the Ministry of Women and Child, they'll tell us, ye to education ke under aata hai. Education ke paas jaoge bolenge to reproductive health program se baat karo. It's, as you said, there's no one space where this is housed. It's a sub-component of so many different things that it's so fragmented in the approach. So to be able to tell people anemia and menstrual health is directly related is sometimes so hard because you don't know who to go to be able to relay this information. So I can go on, but I want to go back to Poonamji and ask you your next question, which is that you've really used storytelling and communication as tools for social change in your long-running programs, especially things like "Main kuch bhi kar sakti hu." What kind of narratives or communication approaches and tools have actually been effective in shifting some of the social norms that you mentioned and leading to real behavior change on ground?
So, I had been grappling for 4 decades on a range of gender issues, including sexual reproductive health rights. And I found the change is very incremental. Okay, we have put women's issues on the agenda, but it's 2 steps forward, 1.5 steps backward. And about a decade and a half ago, I was getting very restless. कि ये change real nahi, like dowry, people like my generation, all of us did everything we could to raise the issue of dowry deaths, dowry laws were made. Where are we? Dowry has gone silently practiced. There is a culture of silence. Now it's called presents, it's called gifts. But we had one staff member in our office from Bihar who got married without a dowry. His whole family and extended family excommunicated him. So dowry is very much, we're all again shocked with Trisha's murder and dowry has come back. But dowry was there. In fact, it flourished in spite of our massive work of the women's movement and laws, legal, gender, and so on. So similarly, I was getting very restless because I always felt if we were going 2 steps forward, we were going 1.5 step backward. There were backlashes of different kinds. And half a step that we had gained, we were doing everything we could to maintain that gain. And I realized that, as I reflected, it was about social norms. But messaging, slogans, Beti Bachao, Beti Padhao, look where we are. Even on sex selection. Slogans do not solve problems. These posters, kitni cheeze, IEC materials. So I happened, while I was very, very restless, I went to the Gates Foundation to comment on a scaling up framework on, I didn't realize, changing social norms. I thought it was a scaling up framework. In the plane, I saw this. I said, wow, yahan to kuch seekh ke aayenge. And really, it's the only big conference meeting I've gone to where I learned everyone knows about the MIT Poverty Action Lab. But there is MIT Media Lab. The Media Lab had done a global analysis, evaluation of IEC materials. And whether it was developed countries, developing countries, poorest countries, and so on, they found that much of the money was wasted. Majority of the work was a waste of time. So what works? I was told entertainment education. And they had evidence, they had evaluated programs in Brazil, but the most famous program was a program in South Africa, where a gynecologist, you gynecologists are great, decided that HIV/AIDS in South Africa, the entire young population is going to die unless you change behavior. So she started a television soap, and then it became a very expanded program. So the minute I heard about that, I caught hold of a good, thoughtful, sensitive director called Feroz Khan from Bollywood. I caught hold of an expert called Professor Arvind Singhal, who's Indian but lives in the US and has led many programs on changing social norms and using entertainment education they knew about. So 1 year, the three of us led a study group along with all our colleagues to understand what works, what doesn't work. We found one UN agency had made 500 episodes, which changed nothing, so we learned what not to do from them. But from this Seoul city in Africa, so we did 1 year of research to learn what to do and what not to do. And then two things we did. We didn't come out with solutions sitting in our offices, all right? We went to the field and did something called positive deviant approach studies. Our formative research, we spent 2 years. Like we wanted an Asha in our soap. Main kuch bhi kar sakti hu. So we did 200 case studies on Asha. So we really did our homework. And also positive deviant, which is a girl doesn't get married while all her friends get married or neighbors at an early age. So what did she do? So it was one teacher who came and spoke to her father. It was, like that. So we brought the Tadka along with these case studies to do the entertainment. And we said we will make a high quality series like in Indian films. Poor people don't want to watch shabby. So even the primary healthcare center, aspirational tha. We created it in Kamal Amrohi studio in Bombay, our own aspirational primary. Our main was a doctor. You have to be in touch with reality. And you have to work with the government. You know, by working with the government, what I mean is there is a government infrastructure. There's ASHA, there's A&M, there's a doctor. So we had all these characters, and we did 182 episodes. And when you really want to do something, the world or universe conspires. So believe it or not, Doordarshan gave us free airtime for these 182 episodes. National Radio nahi kya, All India Radio, 242 radio stations. And we had the most amazing Director General, one of your colleagues from Bihar cadre, IS officer, who made sure that we got everything we needed. So there was government. Then we had 20 experts looking at every script after I and the director used to work on scripts from in the night from 11 to 3. And then we had 18, we had gynecologists, we had psychologists, we had everybody. Also, we decided we are not going to look at women's one issue, family planning or just menstruation. So we integrated all these issues, including menstruation. And in fact, part of our program was Mahino Ke Wo Din. And it was integrated into many sessions. And the storyline addressed menstruation not just as a social, social norms around it, but we were encouraging open conversations. We were not only opening, but we were talking about the dignity of a woman. You know, during menstruation, around menstruation, and we were linking it to all these other issues too. But I want to say that 150 million people, according to BARC, which is the measuring, you know, how you measure, watched it, 150 million people. But BARC is only in urban and peri-urban areas. And this reached rural areas because we were on Doordarshan, media dark areas. And then we went on IVRS. How many of you know integrated voice response system? Mostly. But basically, it's the Facebook of the poor. So people could call, leave a story, and leave a story, ask a question, and so on. And you know how many calls we got on the first day? We were told 250 calls per episode. We got 7,500 calls on the first day. IVRS collapsed. Ultimately, we got 2 million calls. And I'll give you an example of one. We evaluated each one of the serials. We did not want so much money spent and to go to the poor who didn't tell us to come to them or go to women. We wanted to make sure we were getting it right. So IVRS became our monitoring. So we could monitor what feedback people were giving us. But we also, through IVRS, managed to redo the stories. We kept redoing the stories based on the feedback. Then we also did social media at the same time. So 30 million during the season, 30 million hits on there. And the evaluation showed shocking results. So we see, people don't want you to message them. My director used to keep saying, फिर आप message करना चाह रही हैं? अपने दायरे में रहिए. ये entertainment education है. Because the idea is not for them to feel you're lecturing them, but this positive deviant approach. So when we did the evaluation, I want to tell you about 4 things which are very important for men. Our whole approach to menstrual management, including menopause. By the way, I've written my first article focused only on menopause today in Indian Express. Because, you know, WHO is making new guidelines, and 2 people who advocated over there, that's why they got in touch with me and said, will you help us with our communication and behavior change stuff, were Barkha Dutt and Shabana Azmi. Now, you don't expect them to be for No, no, not for menstruation. Menopause. By the way, menstruation also. It was Shabana who publicly raised the first time the fact that girls didn't have access to menstrual health and so on. Anyway, so I want to go back to menstruation and how it was, our approach was important. One is to have conversations with the men. So we had a man, a school teacher who was a wonderful gatekeeper for everybody, you know, girls to not get married early, girls to, so we had this great role model. Then we had his son, who was an alcoholic, who used to beat his wife. His wife, we showed her almost die in childbirth and anemia. And she had anemia, so childbirth, you know, she almost died. So usko seedha kiya humne through almost killing his wife but saving her. And he became non-alcoholic. He stopped beating her. He started practicing family planning, taking care of his kids. So engaging men is very important, not just the men in policy making. We have to engage, and I was so proud to walk in and see a young man talk so comfortably, even more comfortably than us women. So really, we should all give him a hand. Phenomenal. See, this is what we need. He is our role. He has to be our role model for other men to get engaged. We need to engage men, not for women, but for the men's sake too, to make their life more informed, more engaged, and happier, understanding the other sex. Understanding, engaging with the family. You know, hamara nara kya hai? Abhi, the biggest campaign that I'm on to is Desh badlega jab mard badlega. So aise mard to hum, and mard ko badalna mushkil nahi hai, and I'm sure he will say that. Because we have brought up our men badly. They were not born to be patriarchal. They were not born to beat women. They were not born to not want to know about women's menstruation. We brought them up badly and we kept them misinformed. I am not anti-men when I say Desh badlega, Mard badlega, or working with men. I am somebody who believes that it is partly women who are responsible for how women bring up their sons. So engaging men in every aspect of men, not just menstruation, but menopause is equally important because, you know, a lot of relationships break. The mental health issues around this impacts women, impacts men in a big way. So there is just so much we need to do, putting just menstruation at the center.
No, I mean, thank you so much. Firstly, this multi-stakeholder approach of getting media involved, government involved, communities involved, then having doctors, psychologists to build programs, I think I loved that. When you were talking about this, I was getting so inspired. But also, you know, what you said, that you got 7,500 calls. That's what we realize, you know, when you go on into the communities and you create a safe space for conversation, people actually want to talk. So when we say sexual and reproductive health is shrouded in silence, it's not that. It's that we've not created spaces where people can actually speak up safely.
So let me just say one thing. I'm very proud of not just the impact that the evaluations showed of मैं कुछ भी कर सकती हूँ. I'm very proud of the fact that 48% of our viewers were men. 48%. And of which 40% were young people. And you know what it did? It started conversations between husband and wife, between children and parents, especially menstruation. We were thrilled that the conversations between parents and children. And very equally important, you know, while we keep blaming men, the mother-in-law, who can be quite a problem. I was going to use a more stronger word, and then I said, no, I'm a feminist. I cannot say that about another woman. But it is something that was shocking, that daughter-in-laws and mother-in-laws started communication on discussing contraceptives, amongst other things. And you know, these damn serials which show women as nagins have actually, when we were getting feedback from the community, and mother-in-law screwing the daughter-in-law and vice versa, and you know, everyone scheming against each other. The women, when we went to discuss the serial in the community, they told us that our family life is getting affected because of this. And the image of women, it has nothing to do with menstruation, but the image of women, you know, the working girl in these serials is shown as a girl with one foot in her colleague's bed. Then mother-in-laws are troubling, you know, where they didn't have the pratha of mother-in-law treating a daughter-in-law. So we have to also oppose communication which is putting women down.
You were actually working on a study with Columbia University on the role of mother-in-laws in propagating menstrual health stigma in villages and schools. We'll get back to that because, you know, I'm getting eyes from from my team. Yeah, no? She was... So you take it up with her. She take it up. Yeah, please take it up with her. I'm just following instructions. Dr. Khera, I want to ask you about your experience within the government systems and especially with this multi-stakeholder approach. What do you think the respective responsibility of the government, the healthcare providers, the educators, civil society, private sector plays in advancing sexual and reproductive health and menstrual health?
Yeah, bilkul. I think actually, if you read the literature, the common sense says that, I mean, the whatever health outcomes we are noticing, 50% reasons are outside the health department. So there is a real sense in engaging all the department, whether it is education or agriculture for that matter, social sector department. So basically that's why we keep talking about, you know, multi-sectoral engagement, intersectoral convergence. It's very simple to say, but very difficult to practice in the government system. And particularly in the context of, you know, menstrual, not health, hygiene. Because generally menstrual hygiene is one area where something is being done, you know. For menstrual health, nothing is happening actually. So I will not be able to speak. But regarding menstrual hygiene, as on today, you know, you see there is a health department has some role, and then there is a department of, you know, the education, another role, and then there is a department of, you know, water supply and sanitation department, you know. So there are different departments are playing a role, but nobody is taking the responsibility. I think it's a high time, and I still remember when I was in the Ministry of Health, maybe around during the COVID time, you know. So there was a plan by the present government to launch a big, you know, menstrual hygiene program across the country to be declared on 15th of August. And I remembered, you know, I made a proposal in 10 days time, how much it will cost, everything happened. But ultimately we got, you know, stuck up at a point how to dispose. Disposal, you know, became a challenge. And then at the last moment, you know, everything was done, but then there was a lot of confusion, you know, how to dispose of this sanitary waste. And then this could not be taken forward. I think again I heard there is again a movement happening in the Ministry of Health for taking the menstrual hygiene initiative in a big way. But I don't know what is the status, but a lot is being talked about, you know. Now in the context of, you know, menstrual health as a whole, which really impacts the overall health and well-being of the woman, and which really creates, you know, needs a lot of unnecessary visit to the hospitals. I think it's a right opportune. You know, we must, you know, put this, you know, menstrual health as an integral part of the SRHR. But even the SRH, you know, people are not clear. I think we as a maybe policy makers, as a civil society organization, we must, you know, come up with a SRH package, you know. And that SRH package, you know, must consist of, you know, menstrual health as a integral piece. Because I know that there is some kind of some actions are being done, you know, in a silos manner, you know. When we talk about anemia, you know, people start raising the issue of, you know, heavy menstrual bleeding. So I think people are talking in, in bits and pieces. So I think if we can all work together in terms of, designing a package of SRH services, and where the menstrual health is positioned as one of the critical area, then I think we should be able to take this agenda forward.
Do you think the private sector, like what the role of the private sector could be in this?
No, private sector must also understand, that SRH is, as a public health program. Because as on today, if you talk about menstrual health, it's being only dealt by the gynecologist. And if we talk about, any medical ailment or any medical illness for that matter, if it is being dealt by a specialist, so that means the large number of people will not be able to. So that means we have to make it as a public health program. Otherwise, in medical science, there are so many illnesses, You cannot keep every illness as a public health program. But when the problem is so huge, to the tune of 40%, every alternate woman suffering from, menstrual irregularity, I think it's the right time to create a public health program, which addresses the needs, Only then we'll be able to solve it, So private sector means in engaging, Indian Medical Association, maybe, so-called the informal doctors, pharmacists. I think we have to have a big campaign, around menstrual health.
Completely. I mean, we were working in the factories, textile factories of Karnataka. Even occupationally, all the blue-collar workers, women, the private sector could also play such a major role, but it's so hard to convince them to integrate sexual and reproductive health as a priority for their female labor or workforce, because nothing's coming from the top. There's no regulation for it. So I think we really need to have this, like multi-pronged approach with having like a system that can then be executed by all of these bodies, including civil societies and corporates. But
instead of calling, SRH, it's better to call it, reproductive health, I think that serves the purpose, Otherwise, you land up in trouble, You go to a factory, you say, we want to talk about SRHR. They say, no, sorry, we are not interested, Because people cannot register, So I think reproductive health for all matters serves the purpose, And this sexual word is unnecessary creating a problem,
I think I think we need to take the reproductive health steps first and then start integrating beyond. So Tanya, my last question to the panelists before I can take a few questions from our audience, which is that, in your opinion, who will be key players in this tough role of integrating of menstrual health within this larger ecosystem? Like we've talked about bringing everyone together, and that's a really hard thing. How do you think, despite the challenges associated with KPIs, funding channels, and demographic diversity, you've been doing this a little bit with MHAI. Where do you envision we can come together as a coalition, come together?
Yeah, I think, it's important to understand that we are at a different space with where menstrual health is concerned compared to menstrual hygiene, because there the stakeholder ecosystem is very different. There you have your manufacturer ecosystem, trade, etc., related stakeholders. Here we have to be very intentional about looking at what are we starting with. So if we are starting with making the case, as you rightly said, then we need research, we need researchers, we need academia, we need funding from that part of the ecosystem, right? And then if you're looking at policy, we need the right policy stakeholders in the room. So then that also is more granular than just Ministry of Health. We need to see which departments, what are their priorities, and how do we link with those priorities. From a program's perspective, we need stakeholders in the room who bring learnings to the table. We are not starting something new, right? You guys have lessons from your work. There's so many organizations, not just from India, but from across low and middle income country settings, which have demonstrated, these linkages and how menstrual health can be integrated into health systems. I think we need to bring those voices to the table. So we are not recreating the wheel. We are learning from what already exists. So that's the stakeholder types. But I'll go a little bit beyond to say that I think private sector has a role to play in a different way from a services point of view. Like I said, even urban, high income, mid income people do not have access to the right services right now. I think there have been, in the femtech space, there have been some startups that have looked at this as a business model, but they have been pushed to because of the financing pressures towards IVF or nutraceuticals or those kinds of business models. To stay true to their sort of intent, they need the right kind of patient capital, they need the right kind of financing and donor, mechanisms. So that's an ecosystem that also needs to be engaged. I think health insurance has a role to play, because there is, in addition to trying to avoid visits to clinics for, women, we also need to consider the out-of-pocket expenses that they are eventually paying. Right, so that can we include, I know hysterectomy is right now contentious and that's already been covered in the current set of guidelines, but even otherwise, menstrual concerns and disorders is a huge out-of-pocket expense. It's not considered anywhere, even in private insurance. So that's another set of stakeholders. And if you look at it then from a sector point of view, you have SRHR, but look at it from a granular perspective. You have family planning, you have RTI, STIs, HIV, maternal health. So we need to break it down a little bit. We have people working on gender-based violence, gender equity at the workplace. We have people working on women's labor force participation. And all of these people are going to see menstrual health as important from a different perspective, right? How is menstrual health influencing their outcome? Labor force outcomes or productivity outcomes or health outcomes, the relevant ones. So I think it requires a making the case sort of process initially to get the stakeholders together, where we need some research exists, some evidence has been brought together, but also bringing programs, insights from programs together to the table and having a clear advocacy ask for these different stakeholder groups. I'll just mention an example of something that FHI 360 has done globally. They have a group called Contraceptive-Induced Menstrual Changes Learning Group, where they have, they've created different groups. There's a research community of practice, there's a policy community of practice, there's a programs community of practice. And all three communities of practice have worked on different questions that are pertinent to the, their stakeholder types. And then working on figuring out which kind of funding mechanisms can work for those questions and which stakeholders are important to engage within those questions, and how do you get that messaging out, because it's going to be different for all of them. So I think we can do something similar at the India level, but I would also say that we should look beyond at more of a south-south learning agenda kind of a way, because I think more lessons exist beyond. Because it's such a specific issue that not enough people in one country would have looked at it, but there's enough learning across the board.
Thank you, Tanya. I think, I started the organization because I was working in Africa and I realized जो problem Africa में है वही India में access or to menstrual health products, to be able to understand reproductive health, but how it plays out is very different based on cultural context. There's so much we can learn. There's so much innovation happening with pad banks, digital wallets and things like that. There's so much we can learn from each other. So thank you for also bringing that. We don't have time, but we would love to take, okay, we can take maybe, can we do 2 to 3 questions? Okay. Quick 2 to 3 questions from the audience, and can I please request our panelists also to keep it brief as answers? Yes. Can we hand over a mic? Right at the back. If you could introduce yourself briefly and
so basically I'm the founder of Kamakya. I do know some of you here. So basically we've been working in menstrual health and hygiene both for 7 years. So it's only last year when we pivoted from the hygiene sector to health. So we have already, so how we spoke about vulnerable communities, we've started taking medical camps as a cohesive thing with Gynac, PATH, pap smear, physicians, with sectors like police women, traffic police, even we're trying to work with Italy for the sex workers. We've recently done Delhi with house helpers and also Safai Karamchari. According to our findings, what we are seeing is that all of these are public sectors. They all come under municipal corporation. They all come under all this, whatever ministry we talk about. But all they are done is like BP, sugar, weight is something what they're doing on a regular basis. They're not doing a cohesive, because we coming up with like with the house help. I mean, we were standing there and she came with a viral STD, so we had to like like sanitize the place and get everyone to equip. Majority of them have piles, some have third grade uterus erosion. So all of this is coming. We are creating reports. We are trying to get all our reports into the place, writing a paper. But example, like we have conferences like this or we have MHM summits. So when we have advocacy representatives like you in India, they say, okay, present it to us. When we present it to them, they say, we are only working on adolescents. You know, how about you go to this ministry like how you already mentioned. So idea is, even with the help of private sectors, we're trying to get these communities on ground and trying to do the research, but we don't know where to go next to help it to take it to advocacy or whatever we spoke at the panel to get it like a cohesive thing. And it's just not about, I think, reproductive health. What we're trying to also see, and we want more and more organizations to come and just expand this, and we don't know what the
Yes.
next steps to go to.
Do you
for
have a
advocacy.
question that you want to?
Yeah, like where should one go? We've done this work, we're doing it, we want to expand it, we are making reports, but where to take those reports to make sure it is actually implemented and we can take it to some policy or advocacy.
Thank you. I think I resonate very much with her. Who would like to?
Let me try. You know, as on today, menstrual health is not a priority, and I told you in the beginning that whenever we talk about the so-called the RMNCHA program, the focus of attention is reducing maternal and newborn mortality. So this menstrual health doesn't come in the way. It's not killing people actually, right? It is only the morbidity. But I think it's a high time, that's why we are saying that it's high time that we must come up with some kind of a advocacy ask, that menstrual health is a public health issue, and this problem is so huge, and this is a problem which can be managed within the primary healthcare system. You don't require real experts to manage these menstrual disorders. So I think we will have to position it in such a fashion and come up with some kind of a public health approach. I mean, that's my thinking. And once you bring that kind of a public health approach to this problem, and then obviously take it to the Ministry of Health. And nowadays Ministry of Health is also quite keen in terms of taking the agenda of women's health broadly, because now they have been able to reduce maternal newborn mortality. People are speaking about women's health. So I think it's the right opportune if you create a kind of advocacy, a package around menstrual health with all those findings. Thank you. Yes. Sorry.
I think you've rightly pointed out that there's no platform to take your findings to, and an organization alone does not always have the resources to do that kind of advocacy packaging. So I think we were also discussing, and there's absolute need for a platform to get stakeholders together around this issue. We did this with menstrual health in general many years ago. Without funding, so I think we'll probably have to do that again. So we'll get back to you, but I think that's absolutely needed, and some of us in the room should just get together and do this, and we are very much interested in that.
Thank you so much.
One can think of creating mental health alliance or consortium.
Thank you.
One more question. Anyone else in the room? Radha? Yes. Can you please pass it?
So one of the things to Bala I would suggest, just don't focus on menstrual health, do menstrual and menopausal health. They go hand in hand. One is to start at the cessation, but then that is very much connected. So don't wait for another 10 years to add that. That is one thing. The other is intersectionality. The panelists did talk about them, but you spoke about disability. Again, when we talk about disability, many people just focus on physical disability, but also mental disability. That's important. The other thing is menstrual health is again not one shoe that fits all. How is it different for different cohort of women? That is important, whether it's women with disability or tribal women or women living in near seashore. How is it different? We don't have those studies, but it's important to get into that. Poonamji spoke about disposal of sanitary napkins. There's also a narrative which is going on saying that sanitary napkin is adding to climate change. Here we are still talking about access to a sanitary napkin, and there's a whole narrative. It's important that you bring in those people onto your platform so that there's a more cohesive discussion rather than those, disjointed discussions. Also, there are a lot of women who talk about how menstrual and menopausal health affect work participation. We were part when I was in high wage. We started that conversation. I think that conversation needs to go further. So that is also very important. And the second is very important to get everyone on the same board. If you want to really make a change in policy, you need more people with one voice going to the government and making that impact. Yeah.
Thank you, Radha. Can I say something? First, there has been so much effort by everybody in the government and outside on convergence. It doesn't happen. It hasn't happened. But at the national level, unless you go to PMO, that's the only place it happens. But we can't. For something like this, they're not going to entertain us. So at the district level and state level, find state level governments, it'll be easier. And the real convergence that we want to see, make a plan for the district. The district magistrate, under that, we've done a lot of work with district working groups, we call them. And the magistrate or DM, they have different. They are the guys. And I wanted to say something to you, and I'm glad I've forgotten in the interest of time.
No, but also Radha, thank you for sharing, your views on how the programs can be more holistic, even for us as an implementation organization. We're trying to build something called the menstrual vulnerability scale for that very reason, to understand how someone in the deserts of Rajasthan versus someone living in the shores of Kerala getting impacted by menstrual health, someone working in the agricultural field, bent over picking leaves every day for tea, versus someone who's sitting on a factory floor and working in the heat every day. How does reproductive health translate differently for each of these communities? The occupation, the geography, their income levels, their cultural exposure and the surroundings, how does that impact menstrual health and hygiene? So I'm very happy you could bring that forward to us today. And again, this room is people who are interested and excited about this conversation. So if anyone feels that there's any one of these particular intersectionalities that you are more keen to explore with us as an organization, we are so keen to partner, to learn, to build better and more holistic menstrual health solutions for the communities. Other than that, I would really like to thank our panelists today. What an exciting, interesting discussion. We'll share notes from the conversation with everyone who registered and attended the panel discussion today. So if you couldn't scribble because you were so engrossed, please don't worry, we have all the notes that we'll share with you. So thank you again very, very much. A big round of applause for all of our panelists. Vaishnavi, if you could please... can we get a group photograph and then we can... You've got a small plant.
I was sitting at the back of the room and I could see very severe head nodding in some of these points. So I think we're all excited to go back and take these learnings and discussions and see where possibly we can implement some of the suggestions that have come out from panel number 1. We're just going to do a quick chair and name tag change for panel number 2. In the meantime, if you haven't checked out your tote bag as yet, at Bala we love playing games to learn. And that's something we do inside the team and also in all of the projects that we do. So if you want to take 30 seconds to check out how you can improve being a data person and a research person, those games are for you. And if the panel number 2 panelists, if you could join me on stage Until then, please, Dr. Tanvi, Dr. Surbi, Dr. Shweta, and Anshul. Lovely. We're just going to wait for a bit for Dr. Shweta and Dr. Surbi to also join us as well. If someone from the Bala team can do a quick check, please. Thank you. Lovely. Okay, thank you everyone for joining us on panel number 2 of the Missing Indicator. I think through today's conversations, we're really learning that menstrual health is not just a hygiene issue. It very clearly influences education, workforce participation, dignity, agency, gender equality, and equity. Our second panel for today, Catalyzing Collective Impact, brings together voices from healthcare, social science, community systems, and digital engagement to explore what it will take to move menstrual health from the margins into mainstream development conversations and public systems. I'm Parul, and I lead communications and outreach at Bala. And today I'm joined by 4 fabulous, distinguished speakers. I have Dr. Tanvi, who leads menstrual health and hygiene management initiatives at Tata Trust and has extensive experience designing and implementing community-centered menstrual health programs across India. I have Dr. Surbi, who's a gynecologist, a public health advocate, and founder of Sachi Saheli, which has reached more than 5 lakh students and trained thousands of educators and frontline workers across the country. I also have Dr. Shweta, who is a social scientist, researcher, and consultant, whose work focuses on social norms, behavior change, gender, and strengthening community-led development systems. And I also have Anshul, the founder of Youth Ki Awaaz, India's largest civic engagement platform, working at the intersection of citizen voice, tech, governance, and youth participation. Thank you all for being here today on a particularly hot day in Delhi. And I think we're going to start by looking at the broader ecosystem of what it actually takes to create sustainable change. And Dr. Tanvi, you happen to be sitting to the left of me, so we'll start with you. I think we'll also try to do the panel in a mix of Hindi and English, just so that everyone in the room can understand us a little better. So Dr. Tanvi, having supported several programs over years with Tata Trusts, and you've seen different approaches emerge, right from product access and awareness to systems integration and strengthening. So because you lie on both sides, from a funding lens and an implementation lens, what actually separates menstrual health programs from being short-term versus actually being able to create sustainable impact? And where do you see, or what do you see as the biggest opportunity to invest in from all the stakeholders in the room?
Thanks, Parul. So thanks for welcoming me here and to allow me to share my experiences. So being with Tata Trust, we get a good opportunity to scale up and reach out to more the broader geography than the limited geographies. So here there is a stark difference between these small programmings and the systems the programs which focuses on systems. So what happens is when we think of awareness, it is important. Creating awareness is important, but sustainable efforts, if the awareness is not sustainable, it's a waste of time and all the efforts we take. So that's a difference where lot of organization get an opportunity to do one-time awareness and talk about more product and product distribution, where the large-scale program really able to invest in the policy advocacy, invest in the community behavior, right? So the sustainable community behavior is very much possible with the large scale program. When we have a understanding of multiple questions from the multiple community, as the previous panel talked about lot of issues of understanding the menstruation from the broader different areas in a very particular and a fine way. So that's a difference between the the short-term program implementation and the long-term one.
Totally understand that, Dr. Tanvi. I think time really is what we're working against and working with. But if you had to identify one particular contributor to what happens to a weaker, or what contributes towards a weaker program, what do you think that would look like?
First cause of weaker program is funding opportunity, because it's still not a priority issue in the women wellness in women wellness context. It's still not in a list. Everybody quoted that. So the funding opportunities are very, very less. Even though we get funding, it's for the short term phase. Lots and lot of CSR see menstrual hygiene and not menstrual health. So distribution of product, number of outreach is very much important than the penetration. And the large sector sees menstruation as a matter of hygiene and not matter of health. So this is a major issue small organization always face.
I think, like Soumya mentioned in the previous panel, I think we also empathize. I think the form of communication we also use to get people on your side, especially with funders, really matters. I think on the other end, I'd like to actually pull in Dr. Surbi, because when we do long-term programs, we also, our communication also matters when we talk to girls and women, कि हम उनको क्या बताते हैं उनके bodies को लेकर. And once we see a change, they're also able to grasp language या communication, कि they understand that what they're experiencing at that point is perhaps not normal, and then they're able to build that agency to start asking questions कि जो मेरे body में हो रहा है, जो मेरे periods में हो रहा है, ये शायद सही नहीं हो रहा है. But when these questions start coming up, do you think our health systems are equipped to manage and answer the questions that they come with? And also, because you come from a medical lens as a gynecologist, are there certain menstrual health concerns that you think deserve more attention in this current time versus others? Because even in panel number 1, and Dr. Ankita brought up, we're talking about heavy menstrual bleeding, dysmenorrhea, endometriosis and PCOS, which has now also changed in terms of its own understanding. So what do you think we need to focus on right now when it comes to these questions that our participants have, but also in terms of the medical space?
Thank you, Parul. And first of all, I want to congratulate Bala, क्योंकि जब मैं सबसे पहली बार बाला से मिली थी तो मैं बहुत सोचती थी इतनी छोटी सी बच्ची क्या करेगी कहाँ इस सेक्टर में आ गई, और मैंने उसको काफ़ी जज भी किया था. एंड आई एम रियली प्राउड ऑफ यू कि तुम यहाँ पहुँचे. मुझे सच में अपने आप को गलत साबित करने में बहुत अच्छा लगता है कि इसने मुझे गलत साबित किया कि एक सो थैंक यू सो मच फॉर द होल टीम जिसने भी यहाँ पहुँचे. एंड द राइटली अभी अगर हम बात करें ना कि कहाँ गैप है, तो बहुत सारी लेयर को एक साथ कंबाइन कर रहे हैं कि हम बहुत सारे अलग लोग अलग जगह पे हैं, जहाँ पर कुछ लोग अभी बिल्कुल बेसिक फैसिलिटी से भी महरूम है, जिसे कहना चाहिए कि टॉयलेट्स ही नहीं हैं. उनसे हम कहें कि टॉयलेट को ना बंद ढक्कन में फेंकना चाहिए पैड को, और इसको यहाँ डिस्पोज करना चाहिए ये वाला पैड. तो हम बहुत अलग अलग लेवल पे बात कर रहे हैं. कुछ लोग बहुत एजुकेटेड हैं, वो बात कर रहे हैं कि जैसे सर ने कहा कि डिस्पोजल इज़ अ इशू. तो जो वहाँ बैठे हैं उनके लिए जो ये लाइन कवर कर चुके हैं, मतलब अगर हम कहें ना कि मेट्रो दिल्ली के एक कोने से दूसरे कोने में जाती है, तो हम अलग अलग स्टेशन पे खड़े हैं. कोई दिलशाद गार्डन पे खड़ा है, तो कोई साउथ दिल्ली में खड़ा है, तो कोई महरौली पे गुड़गांव बॉर्डर मतलब छूने वाला है. तो हम सबके लिए एक जैसा नहीं सोच सकते यहाँ पे खड़े हो कि क्या वो गैप है, क्योंकि हर किसी का गैप बिल्कुल अलग है, और हमें उसको ना स्टेज वाइज ही समझना पड़ेगा कि गैप कहाँ है. वो बच्चे जो फर्स्ट जनरेशन लर्नर हैं, उनके लिए स्कूल जाना इतनी बड़ी बात है कि वो इस बात से खुश है बच्चा स्कूल जा रहा है, बच्चे ने पढ़ना सीख लिया है. अब उसको हम जाते ही अगर ये बोले ना उसने कभी मेंस्ट्रुएशन ये सब क्या है, उसको ज़्यादा मतलब नहीं है, पढ़ना सीख रहा है, बच्चा स्कूल जा रहा है, 12 साल की हो जाएगी, 12 मतलब 12-14 साल में फिर घरों में काम करेगी, ये सब करेगी. उसको आप कितना भी समझाओ उसके लिए वो इशू है ही नहीं. कमाना कब शुरू करेंगे, दैट इज़ एन इशू. गाँव में छुट्टी पर 2 महीने जाना ही है, वो उसके लिए इशू है. उनको आप नहीं समझा सकते बहुत ग्रेट थिंग्स जो है. जब मैं मेडिकल में कर रही थी ना MBBS और MS मैंने जब किया, तो मेरी इतनी मोटी बुक में सिर्फ एक चैप्टर था मेंस्ट्रुएशन, सर जैसे भी बोल रहे थे, और मतलब ऐसा लगता है इतनी बड़ी दुनिया में एक छोटा सा डॉट है, वो एक छोटा सा चैप्टर है, और जब मैं इधर मुँह घुमाती हूँ ना तो मुझे लगता है बहुत सारी जिंदगियाँ निकल जाएंगी, बहुत सारे जन्म निकल जाएंगे इस चीज़ छोटी सी बिंदी को, मतलब इस बिहेवियर चेंज के इस छोटे से एपिसोड को, जो ये लगता है ना मेंस्ट्रुअल डिसऑर्डर एक चैप्टर को यहाँ दुनिया में जब यहाँ देखते हैं ना, तो इतना पर्सपेक्टिव, इतना चेंज है कि मैं पूरी पढ़ाई लगा दूँ ना और हर इंसान तक सिर्फ एक बेसिक नॉलेज पहुँचाऊँ तो मुझे बहुत सारे जन्म लेने पड़ जाएंगे। अभी भी ये है, क्योंकि हर जगह गैप बिल्कुल अलग लेवल पे है, जो जहाँ बैठा है उसके लिए वो गैप है। अगर मैं एज ए गायनेकोलॉजिस्ट बैठती हूँ तो मुझे अलग तरह के गैप्स दिखाई देते हैं, जब मैं एज ए एजुकेटर जाती हूँ स्कूल में तो मुझे दूसरे गैप्स दिखाई देते हैं। तो कभी कभी ना इतना दिमाग परेशान हो जाता है कि करना क्या है कैसे करें, देन समझ में आता है कि स्टेप वाइज ही चला जाएगा, सारी चीज़ एक साथ एड्रेस नहीं कर सकते। एंड एक और चीज़ समझ में आती है कि सबसे इंपॉर्टेंट चीज़ है बिहेवियरल चेंज। अगर आप कितना भी एजुकेशन में आप सीरियल बना लीजिए, मतलब मैम की बात से बिल्कुल डिसएग्री नहीं कर रही, मैं कह रही हूँ चाहे आप बहुत सारी, जैसे ms.org ये बहुत अच्छी वो बनाता है, कार्टून फिल्म्स बनाता है, अगर हमारा बिहेवियर चेंज ही नहीं हो रहा है कि हम उसको एक्सेप्ट करें, हमें वो नागिन ही देखनी है, तो आप कैसे समझाओ उनके दिमाग में, कैसे घुसाओ ये बात कि ये इंपॉर्टेंट इशू है। तो बहुत इंपॉर्टेंट है। और जो जैसे मैम अभी बोल रही हैं डॉक्टर तन्वी, बिहेवियर चेंज में फर्स्ट स्टेप होता है अनलर्न करना। पहले ये तो समझाओ कि जो आपने अभी तक सीखा है वो गलत है, या मतलब वो आज के हिसाब से उतना सही नहीं है, पहले अनलर्न करना सीखें। ये इंपॉर्टेंट चीज़ है, इस पे बात की जा सकती है और करनी चाहिए। फिर उसके बाद एजुकेशन, मतलब हम एटीट्यूड बदल रहे हैं, फिर उसके बाद नॉलेज, एंड फिर उसके बाद प्रैक्टिसेस बदलती हैं कहीं जाके। और अगर हमने जब ये सोचा बहुत सारी बार, तो हमें लगा कि हम एडोलेसेंस से शायद शुरू करेंगे, क्योंकि जहाँ पर सवाल शुरू हुए हैं तो शायद उनको उस जगह पे एड्रेस कर दिया जाएगा तो जल्दी बदलाव आएगा। क्योंकि जहाँ सीमेंट हो चुकी है ना चीज़ें, में बहुत मुश्किल होता है, कितना भी समझा लीजिए उनको नहीं समझ में आता है, कितना भी आप मेडिकली समझा लीजिए। दूसरी बात, जैसे सर ने भी एक बात ये बोली थी कि हमारी जो नॉलेज है ना, जो मेडिकल नॉलेज है, वो इतनी टफ है कि उसको कितना भी पैलेटेबल बनाया जाए, कितना भी बायोअवेलेबिलिटी के हिसाब से बनाया जाए, उसको एब्जॉर्ब करने के लिए उस मेडिकल नॉलेज को आप जिस फॉर्म में लेना चाहते हैं उस फॉर्म में बनाने में बहुत मेहनत और टाइम लगता है। मतलब उसको इतना डाइल्यूट करना पड़ता है बहुत सारी चीज़ों को। तो अगर हम यहाँ थे, फिर ऐसे आ जाता है सवाल, एक डॉक्टर हो क्या आप ये कैसे बोल रहे हो, मैं ये बोलना नहीं चाहती पर आप सुनना ये चाहते हो, तो मुझे थोड़ा सा इस फॉर्म में बताना पड़ेगा, चीज़ों को वैसे समझाना पड़ेगा। तो गैप, अगर आप एक पार्ट को भरने चलते हो तो दूसरा वाला आपको टोकेगा, ये पार्ट तो खाली रह गया, यहाँ तो आप कुछ कर नहीं रहे हो। तो यहाँ पे हम सबको ये बात समझनी पड़ेगी कि हम जिस गैप पे काम कर रहे हैं हम उस पर फोकस करके, मुझे तो ऐसा लगता है कि काश कभी ऐसा हो कि हम एक एरिया लें और उस पर सब लोग अपने अपने गैप आइडेंटिफाई करके एक मॉडल बना के दे सकें कि ये किया जा सकता है, ये डूएबल है। बहुत सारे लोग वॉशरूम्स पे काम कर रहे हैं, सैनिटेशन पे काम कर रहे हैं, बहुत सारे लोग प्रोडक्ट पे काम कर रहे हैं, बहुत सारे लोग एजुकेशन पे काम कर रहे हैं, सभी की ज़रूरत है। और एक मॉडल हम कहीं बना के मिल के दे सकें, उन सारे गैप्स को समझ सकें, तो मुझे लगता है कि शायद जो लोग को अभी नहीं समझ में आ रहा है क्या करें, सब हमारे ही जैसे तो लोग हैं, कोई ऐसा तो है नहीं कि अलग से कोई अवतार उतर के आते हैं सब चीज़ों को, प्रॉब्लम को सॉल्व करने के लिए। तो वो हमारे जैसे लोग को हम ही एक मॉडल बना के समझा सके कि डूएबल है, किया जा सकता है। तो जैसे सर ने कहा कि फिर बहुत सारे वो जो चैलेंजेस आते हैं ना, सब अपना अपना पार्ट प्ले करेंगे तो मुझे लगता है हम चीज़ें कर पाएंगे।
Like the note of positivity, Dr. Subi, that we can do this and I'm sure we can. But जैसे आप adolescence के बारे में बात करते हैं स्कूल में, and navigating being an educator and being a gynecologist, जब हम स्कूल में जाते हैं, so a lot of the teachers come to us कि thank God आप आ गए, क्योंकि हम ये बच्चों को नहीं पढ़ा सकते, हम बाकी सब कुछ सिखा सकते हैं, नहीं पढ़ा सकते हैं। And I think some of us in the room as stakeholders, हम काफ़ी लोग implementation agency से भी हैं, and sometimes we do this work directly and sometimes we also lean on government support. And I think the first people we look at कि government support मिल जाए, we're like अगर हम आशा दीदीज़ को ट्रेन कर दें, आंगनवाड़ी दीदीज़ को ट्रेन कर ले, then they'll be able to mix that role of being an educator but also bringing in some science or biology. But perhaps we have to rethink this, and Dr. Shweta, I'll pull you in over here because we're witnessing a huge dependence on these government bodies to train them to take the work ahead. But do you think, and I'm sure we also understand, we read so much news about how this constantly increases the pressure on ASHA workers, Anganwadi workers, already unke paas 100 cheezein karne ke liye, and to add this to their work sometimes becomes quite complicated. So what role, when we do this as implementing agencies or as partners who work in this space, what role does community ownership play in all of this when we're talking about mixing education, mixing scientific advice, mixing talking to adolescents, mixing playing that teacher but also that parent in this situation?
First of all, thank you for having me, Bala, and it is pleasure to be part of this panel discussion. Thank you, Parul, for this very important question. Let's believe that, and we hope that menstrual health is increasingly being recognized into policy frameworks. But the real challenge is how to integrate it to make to ensure it that it is integrated effectively and sustainably in the system. So, from my experience and understanding, is that evidence from many low and middle income countries shows that putting pressure on frontline workers, adding pressure on frontline workers without adequate without adequate capacity building, resources, support system, it is going to be like implementation fatigue for them and reduce the sustainable changes. So definitely there is a need for an approach which is system strengthening in nature. So I would like to say here that government can integrate menstrual health in various touch points and platforms. Those are there. I mean, nutrition program, adolescent health programs, and child and maternal health, community based self-help groups. So this way we can, and of course, when I'm talking about the NGO government, and definitely there is collaboration of civil society organization, we can reduce the duplication, and there are bright chances of sustainable change what we are looking for. If we talk going beyond, and if of course mainly for training perspective, so training is definitely essential when we are talking about the frontline worker, but it must go beyond information. There is really a need for communication skills, gender sensitive counselings, and support mechanisms and other things. And they are also looking for supportive supervisions and education materials and practical tools and referral mechanisms. Importantly, when we are talking about menstrual health, it is shaped by the social norms, culture practices, and power structure. So it is very much important, as you asked me about the ownership, it is very much important to understand the interconnectedness of attitudes, behaviors, and social norms when we are talking about the very alarming and alarming issue and the need of the time, though it is from history, and it is like the truth of life. So it is the need of our to understand the interconnectedness, not only the interconnectedness, what all areas it affect, I mean education or health, livelihood, and economic productivity. Yeah, so I'm coming back to the point of ownership. So it is very much important to engage communities, self-help groups, teachers, parents, of course, fathers, mothers, adolescent boys. It can help in to create sense of ownership, community ownership in the community, which is very much needed. And ultimately, when we are looking for integration of menstrual health, um, it is it is very much require to to invest in people's systems and social environment simultaneously.
Well put, Dr. Shweta. I think when individuals and communities are empowered, then they're able to actually take ownership of what everyone would like them to take ahead and they themselves. But what really stood out to me was when you said ki intergenerational conversation honi chahiye. I think in some of our programs we have tried to have the grandmother, mother and the child sit in the same room. And sometimes it's a very intimidating experience for us also कि अगर हम contraception के बारे में बात कर रहे हैं and let's say we're demonstrating how to correctly use a condom. Instantly everyone's like नहीं नहीं अलग अलग बैठा दो हम सीख लेंगे पर हमें अपनी बेटी के सामने ऐसा नहीं करना है और I don't want to do this in front of my mother-in-law. We were talking a lot about that in panel number 1 as well. But yes, I agree that I think empowerment and ownership actually go hand in hand. But Anshul, I'll bring you in there when I was talking about information access and how a lot of us in the room might want to talk to different demographics or age groups together in one sitting. But on the flip side, this generation is equally becoming increasingly online. And in the space of AI, M-dashes and digital and tech and all of that, it's kind of difficult to control the information and who has access to what. So, and this is all algorithm driven content, right? You're shown what you constantly interact with. So how do we actually ensure that young people access this information safely, but it's also accurate and responsible?
No, that's a great question, and thank you for having me here. My experience with Bala is also fairly old. I got to meet Soumya and Aradhana first in 2018, I think, when we were just starting our own program on menstrual hygiene called Period Part, and there was an Action Network Fellowship that we had just launched, and from there till now, it's absolutely amazing to see the organization having grown so much, and I'm delighted to be here. The question that you ask is absolutely critical, and I'll answer it in a couple of ways. First is that, we work in more than 80 low-income communities, 80 cities across the country in low-income communities with different kinds of adolescents on different kinds of issues. One thing that we see very common, and it's a rising trend across all of these communities, is that the moment there is first digital access that a young person or an adolescent gets, they also immediately want access to new technology, which includes AI, right? Just for context, out of the billion new users that ChatGPT has in the last 5 years, about 200 million are in India, predominantly young people. These are the official numbers. Unofficially, it's probably more because India also has shared devices. So one family might be using the same ChatGPT or AI chatbot to access and have conversations. I'll give you examples of 2 different issues and then come to menstrual health. 2 of the most predominant conversations that young people from low-income communities are having with AI chatbots are, 1, on loneliness and mental health, and 2nd, on domestic violence. These are issues that young people are seeing around them, but they're not articulating it as mental health or as domestic violence. So what happens in most of the cases is that the response that they end up getting is a very westernized response of what a culturally, different young person is going through in India. And that leads to either seeking information that they can hence relate with, which is often misinformation, or information that is entertaining on Instagram, may not be accurate, and so on and so forth, right? So one thing that we are constantly noticing is that when AI is responding to young people's real questions about real challenges, the information that is being given to them is not culturally contextual and hence not relatable. The same thing is happening in menstrual hygiene and menstrual health and SRH. Firstly, no adolescent in India is going out and saying, I want to talk about reproductive health. I want to talk about menstrual health. The language that they're using, the words that they're using are not these technical terms. The information that is being provided to them is in these technical terms, right? So no, you won't find a young person going out and saying that I want to talk about depression, right? Even today, You will instead have a young person go out and say that I'm feeling lonely. Why do I feel lonely even when I'm surrounded by friends? That's the kind of question that a young person will ask. Similarly about their bodies, similar about their sexual experiences, similarly about, you know, whatever changes that they're seeing around them, whatever lack of information that they're noticing around them. So the first thing that I think we need to focus on is how do we build this culturally contextual layer of content that AI can be trained on, because currently AI is being trained on very westernized information or very, you know, highbrow academic information. The second is for us to really be able to build this culturally contextual layer of information. Are we really listening to communities? How do we build the capability to listen to the way communities are talking rather than telling them how they should be talking, right? So there's a very big difference between the two. A lot of organizations work on, you know, storytelling, narrative building. We are also one such organization. But the biggest failure of any organization working on communications is that we often want to go and train communities on how to communicate. We don't want to actually listen to how they already communicate, because it's not like they're not talking about these issues. It's just that the language is different. Doesn't mean that it's wrong. Doesn't mean that it is not valid, right? So how do you produce more information in the same language, make it something that is palatable, make it something that is accessible, and make it something that is large scale enough that AI models can actually be trained on it? That's the big question that we are grappling with when we think of health data, right? And now the challenge is that you also have, I mean, menstrual hygiene, menstrual health, SRH is not existing in isolation anymore. You also have climate change that is making it all the more difficult. You also have more specific issues like antimicrobial resistance that is making it a lot more complicated for people to access proper healthcare. So how do you have these complicated conversations in communities where even access to education is difficult, or even the capability to have these conversations is difficult? So obviously a young person is feeling that, okay, let me just go and talk to ChatGPT, because one, there is no judgment. Second, it's one-to-one conversation. No third person can see it. I can also enable my temporary chat. And third, whatever information I get, then I will have to, on my own, alone as a 16-year-old sitting in some city in India, have to figure out what to do with it, right? So I feel like the challenge is lack of culturally contextual information, and that's the real opportunity. So I feel like organizations in the room, you know, of course, organizations like Bala, anybody who's working in communities where there are these real lived experiences, we have to find good ways of documenting it, and good ways of making it public, archivable, and accessible for the larger landscape to really be able to make technology a lot better. And the last part that I do want to mention here is that if you leave AI aside, if we fully leave, you know, ChatGPT and AI chatbots and Claude, etc. aside, Instagram has now become the television of this generation. What TV was for when I was growing up is what Instagram is for what young people who are growing up now, right? The only problem is I couldn't take the TV with me when I was going out. Now people can take the television with them, right? So they have constant stimulation all the time that they're dealing with, right? On top of that, the appetite for good quality information because of this constant stimulation is going down, because you don't want to engage deeply anymore. So do you sit a young person down and tell them, no, you have to engage deeply? Or do you find a way to hook them in those 3 seconds that you really have, right? That's the question that we need to sort of grapple with. I know the answer for myself. You know, I know what we need to do as an organization. Different people have different approaches, but I feel like we need to truly understand how to reach young people and make them feel invested in the conversation in the most organic way possible, rather than treating them like people who have to necessarily be beneficiaries of something, or a top-down approach needs to be put, or an onus needs to be shoved on them to figure it out. So I think that's where we have the opportunity to both use technology and also mold it to be able to cater to this issue a lot better.
I feel no notes, 10 on 10 answer. That was great, but I think, Anshul, what really stood out to me was the cultural contextualization. I think at Bala, what we do is we ask even the simplest of questions ki, is community kya bachchedani ka word use hota hai ya garbhasha ka word use hota hai? And like you said, those 3 seconds, instantly by understanding which word is used in this community, helps us create that connect. It's never a talk-down approach. It's like, let's sit together and understand the issue. And particularly as someone who works in communications, Dr. Ankita and I were putting together a set of euphemisms that people used to talk about periods. And the current new thing is ki, aaj mera birthday hai, मुझे एक बर्थडे केक का पीस चाहिए. And a girl asked me this, and I had no idea what was happening. I was like, अच्छा चलो workshop के बाद हम खा लेंगे cake. She's like, नहीं दीदी अच्छे से सोचो मैं क्या पूछ रही हूँ. And then I understood that she's on her period and she would like a pad from me. But just as we talk about cultural contextualization, I think this is also a fun part of language and working with communities, that it's a two-way learning process. It's never us telling them, these are the words that you have to use and this is what you have to understand from us. Okay. I know that maybe some of us may be feeling restless, and I know as everyone is in this room is pretty much part of the development sector and panelists, I think the one thing that's often asked for by us is, ye jaldi jaldi karo, thoda rapid change hame chahiye. But since we can't do that, and that's not really feasible, we're going to do the next best thing, which is a rapid fire for our panelists. So it's going to be so rapid that you have 30 seconds each to answer the question. We may take 10 seconds extra to pass the mic down, but that's totally okay. And in no particular order, doesn't matter. So Anshul, since you're holding the mic, we can start with you. So rapid fire question number 1 is, what is the biggest barrier to effective government-private sector partnerships in menstrual health today?
I think the timelines are misaligned. Private sector is wants to move really fast, and government will take its own time. Yeah.
I think the biggest challenge is fragmentation. Different actors are working differently. They often work with different objectives, different timelines and success metrics. Government focus on equity and the private sector actors hain, they may focus on innovations and accountability, market accountability. So it is very important to have a strong coordination and clear definition of objectives so that the partnership, एक बहुत अच्छी partnership हो सके.
Being an NGO, मुझे तो ये लगता है कि लोग काम चाहते हैं हम कॉर्पोरेट जैसा करें और एक्सपेंशन हमारा गवर्नमेंट जैसा हो. वो सबसे बड़ा चैलेंज है कि उनको ये लगता है कि रिपोर्ट कॉर्पोरेट की टाइप से आनी चाहिए, डेटा ऐसा मिलना चाहिए, और जब फंडिंग की बात आती है तो उनको लगता है इतना क्यों देना है. तो बिगेस्ट चैलेंज कि समझ लो दो डिफरेंट सेक्टर एक साथ कैसे आते हैं.
I agree with Anshul. It's a misalignment between two sectors. Our experiences, when we want to work with a government, they want scale. Okay, they will not work with you for one district, two district or blocks. They want you to nahi aap sare district le lo. They don't want to work with multiple 5 to 6 organization, right? So they want scale, and organization wants to deliver. They wants to catch up. They wants to show. We are talking about research, evidence generation, you know. So it's a huge misalignment in the objective, goal, where we are unable to match. Where now the themes which suffer out of it is schooling. The whole school infrastructure suffers out of it. Primary health setup again get a fragmented intervention. There is a power play. Some district commissioners are in power, they utilize their power well. So some district it happens, somewhere it's not happening. So one organization may get a successful intervention in government of Maharashtra in limited district, but otherwise in other state they won't enter at all because they won't get any permission. So this is a huge misalignment which is contributing.
Lovely. In this room, I know there are lots of young people and they may be interested in joining the menstrual health space. So Dr. Tanvi, हम आपसे शुरू करेंगे कि what is the skill you want these young researchers, development practitioners to develop right now?
I would suggest bridging the gap. India is always great in intention. We are great in planning, structurized, strategizing, but the moment it comes on implementation, because we are very heavily populated country, we don't understand very clearly what's happening, what schemes are designed for what people. So when we say the ASHA and ANM workers are heavily burdened, but they are in one community, okay, they are handling those 500 women the 300 adolescent girl in a same community. Okay, but if we able to understand what is designed for whom and who are executing it, so the young people should study that first and put that effort into the institutional integration of menstrual health. Okay, that will help the sector on larger purpose. Here, when I said the CSR thing earlier, it's our role to explain them what is more important. Is the temporary programming will help in numbers? Yes, but for sustainability, no. As Dr. Khera rightly said, there will be new batches coming in every year, and year 2 years program in one geography will not help because schools are not equipped, trained and built with capacity who will keep that messaging rolling. Okay, there are multiple factors. So it is our role to define our goals and objective very clear, and then pitching our programs in that way.
So, can you please repeat the question? The same. Sure. I was thinking.
We have lots of young people in the room who may be interested in entering the menstrual health space. तो आप क्या recommend करोगे कि what skills should they develop right now in 30 seconds? Okay. Not developing the skill, but आपका आंसर.
मुझे लगता है कि सबसे इम्पॉर्टेंट स्किल होती है सबसे पहले अपनी बॉडी को समझना शुरू करें. मेंस्ट्रुअल हेल्थ कोई अलग से कोई ऐसी चीज़ है जो कि हमारी बॉडी में जैसे कोई ऐप नहीं है कि डाउनलोड हो जाएगा, या हमारी बॉडी में चेंजेस हो रहे हैं, उन चेंजेस को राइटली समझ लेना. मैं अगर जैसे ऐसा जब हम बात कर रहे थे सेक्सुअल एंड रिप्रोडक्टिव हेल्थ की, हम बॉयज़ को छोड़ देते हैं. बॉयज़ में आज भी नाइटफॉल मास्टरबेशन को लेकर उतने ही सारे इश्यूज़ हैं जितने कि गर्ल्स को मेंस्ट्रुएशन को लेकर है. जब हम इस सारे टॉपिक को बात करते हैं तो अपने को समझना, अपने साथ वाले जो भी आपके कलीग हैं, मतलब स्टूडेंट्स हैं, जो भी आपके आसपास हैं, तो कुछ अलग से नहीं लाना है, कुछ अलग से नहीं आएगा. सिर्फ अपनी बॉडी को समझना इज़ द राइट स्किल. क्योंकि जब हमारा खुद का बिहेवियर चेंज होता है और हम अपनी बॉडी को राइटली समझते हैं, व्हाट इज़ नॉर्मल, एबनॉर्मल, अलार्मिंग, हमें इस लेवल की नॉलेज होती है अपनी बॉडी के बारे में, तो वो आपके आसपास ऐसे ही स्प्रेड होने लगती है, लोगों को समझ में आने लगता है. अगर आप ओपनली बोल रहे हो यार मेरे को तो पीरियड्स में ना बहुत क्रैम्प्स होते हैं, मेरे को तो थोड़ी देर रेस्ट करना ही पड़ेगा, तो अगले के दिमाग में सवाल आता है अच्छा ये बोला जा सकता है, अच्छा रेस्ट करना अलाउड है. तो आप अगर बोल सकते, मतलब आपके बिहेवियर से ही सिर्फ बहुत सारी चीज़ें बदल जाती हैं. आपके घर में आपकी मेड है और आप उसको बोलते हो कि मेरे को तो पीरियड्स आ रहे हैं, तेरे को भी अगर कुछ दिक्कत तो मैं तो अपने लिए बना रही हूँ, तेरे लिए भी बना दूँ क्या, या पीरियड से तो छुट्टी ले ले, तो मेंस्ट्रुअल लीव मेरे लिए होनी चाहिए पर उसके लिए नहीं होनी चाहिए. ये वाला जब हम एटीट्यूड लेकर आते हैं, तो जब हम कहते हैं ना पॉलिसी मेकर सोचते नहीं है हमारे बारे में, तो जब हम होते हैं अपने घर में वो पॉलिसी मेकर, तो हम अपनी मेड या उन सर्वेंट के बारे में ये सोचते हैं यार ये फिर छुट्टी लेगी, इसके पीरियड आने वाले हैं. तो उस वक्त हमें भी ध्यान रखना चाहिए कि इनके ऊपर भी कोई है जो इनके लिए पॉलिसी जो हम डिज़ाइन. तो आपका बिहेवियर जो चेंज होता है, आप अपनी बॉडी को जब समझते हो कि मेरी बॉडी में, छोटा सा एग्जांपल दे रही हूँ कि बॉडी पार्ट्स के नाम बताना भी सेक्स एजुकेशन का ही पार्ट होना चाहिए. हम यहाँ के नीचे सब गंदी बात अगर कर देंगे, तो जब एडोलेसेंस में, जब प्यूबर्टी में मेरी ब्रेस्ट एनलार्ज हो रही है, तो मुझे लगेगा इसके बारे में तो ये गंदी बात है, तो मैं कभी बता ही नहीं पाऊँगी मुझे पेन होता है, मुझे ब्रा की ज़रूरत है, क्या करना है, मेरी बॉडी क्या फील कर रही है. एज ए बॉय मुझे समझ नहीं आएगा कि मेरी बॉडी में इरेक्शन क्यों हो रहा है, मॉर्निंग इरेक्शन क्यों हो रहा है, ये कोई गंदी बात तो नहीं है, नाइटफॉल क्यों हो रहा है. तो ये सारी गंदी बातों पे बात बचपन से धीरे धीरे थोड़ी थोड़ी भी शुरू करी जाए. अपनी बॉडी को समझना और उसके बारे में सवाल पूछना, अगर हम इतना भी आसान कर लेंगे तो ये एक बहुत बड़ी स्किल है जो बहुत आसानी से हम लोग एक दूसरे को दे सकते हैं. मतलब
I would suggest to develop a social norms and system perspective. I mean, as I said earlier also, that it is important to understand the dots among attitude, behaviors and social norms. It is very important. Secondly, when I am saying the systems along with social norms, I mean that because it affects different aspects of life, whether it is the livelihood, nutrition, education, and our participation in workforce. So understanding of all these nodes and the areas जहाँ पे menstrual health affect करता है हमारे पूरे जीवन में. So it is very much important to understand all the dots and the aspects.
I'll try and keep it very short. I think whoever is interested in working in this space, आई थिंक हमारे लिए सबसे पहले ये सीखना ज़रूरी है कि हम सुनें कैसे before we make our program. How do you listen before you make whatever you're going to make? Because I feel like that is probably the most important thing. A lot of information comes our way. We need to be able to process it in a way that it responds to what the communities that we're working in actually need. हम अपना assumption लेके ना जाएं कि हमारे हिसाब से इनको ये चाहिए, हमारे हिसाब से सबको menstrual cups यूज़ करने चाहिए, हमारे हिसाब से ये disposing का तरीका होना चाहिए, and so on and so forth, right? So I feel there is a lived reality. If we listen to it and then think of how do we deploy our intervention or how do we make it, that is probably the most important thing.
Lovely, well said, panelists. I think we'll do one last rapid fire question. This could be a fun one, perhaps. What's one menstrual health taboo, misconception, superstition, understanding you've encountered that surprised you the most? Dr. Shweta, would you like to start?
Okay, first of all, the idea around purity and the pollution, that is really surprising. In many communities, though we think and believe that it is due to what is not allowed and what is allowed due to the lack of information, but this is also very much true from my own experience that the restrictions during menstruation because of social norms, cultural practices, and the power structure or the patriarchy where we live. So this is really surprising, and we should think over it and work toward it.
What surprised me कि जो hypocrisy है ना सोसाइटी की, पूजा नहीं करनी है, एकादशी में दीपक नहीं जलाना है, मगर शादी जिसमें कन्या का दान करते हैं यज्ञ करके, शादी की डेट कभी चेंज नहीं होती पीरियड्स में क्योंकि वहाँ पैसा लग गया है वहाँ हो गया. तो ये सोसाइटी दो तरह से एक्ट करती है. कहीं अगर आप अकेले खड़े हो तो आपको बोलेगी अरे दिया क्यों चला दिया, ये क्यों कर दिया. यही सोसाइटी बड़े बड़े फंक्शन कर रही है शादियों में. ये सोसाइटी जो कहती है कि भगवान नाराज़ हो जाएंगे, वही सोसाइटी में कहानियाँ सुनाई जाती है कि द्रौपदी का जब चीरहरण हो रहा तो भगवान कृष्ण खुद बचाने आए थे. जब वो द्रौपदी बोल रही है कि मुझे पीरियड्स हो रहे हैं, मैंने तो ऋतु स्नान भी नहीं किया, मैं एक कपड़े में लिपटी हूँ, मुझे दरबार में क्यों लेके जा रहे हो. ये सोसाइटी हमें कहानियाँ सुनाती है कि भगवान कृष्ण खुद बचाने आए थे. उन्होंने नहीं कहा कि हे देवी तुम तो पीरियड्स में, मैं कैसे आऊँगा ना. तो वही सोसाइटी हमें कहती है कि ये नहीं करना है. तो ये सोसाइटी के नॉर्म्स जो बदल रहे हैं, और हम मतलब सिर्फ कुछ नहीं करना, एक छोटा सा आईना दिखाने से भी चीज़ें बदल जाते हैं. अगर आप ये बात सिर्फ समझा पाओ कि क्या सही है, फिर आप ही बता दो टाइप से.
So there are two things which really surprised me. One is an example from our Assam intervention. We all know that in Assam we worship Kamakhya Mata, and it's a goddess of menstruation. So their menstruation is being celebrated, okay? But women, because there are I think 2 or 3 sessions of Bihu being celebrated in Assam, women started taking pills either to delay or to get periods earlier. So despite we are celebrating, there is a great level of acceptance of periods, okay? There is a kind of flexibility about communicating about periods, but worshipping during any festival, it's a taboo. So when we are discussing that normalizing conversation will help, reduce such to reduce existence of such myths and taboos, I don't feel so. Like ma'am said ना कि डाउरी पे इतना काम किया बट वो तो साइलेंटली अभी भी एग्जिस्ट है. तो कहीं मुझे डर लगता है कि नॉर्मल इतने सारे स्टेट्स है साउथ इंडियन स्टेट में, टॉकिंग अबाउट मेंस्ट्रुएशन इज नॉर्मल. दे आर डिस्कसिंग बट they are preventing also at some scale. So normalizing conversation is important, but integration of men and boys is again very, very crucial. So it's still a rapid fire. I'll mention about one campaign of Mahina aa gaya, which we developed, which is targeting mother-in-law, husband, the ASHA workers, as well as a mother as a community. That's we develop out of ethnography. Behind that was a sense ki हम जो बातें कर रहे हैं really will that help. So that's a really है. The second thing is we ourselves in a developmental sector, few people who are sitting here talking about menstrual health so strong, are we practicing our choice? We do not. So we talk, but when time comes, we have linked our menstruation to karma somewhere, and I am very sure women having kids may go back and follow the taboos again. We have linked the menstruation and karmas very strongly.
Okay, we can pass it to Anju.
I think everything that I could have thought of was covered, but I don't have like a misconception, but I feel like there is still a big taboo when it comes to women's health and in the workplace, and that still remains a very, very big issue. My own sister had to go through it. She has been dealing with endometriosis for a very long time. Thriving corporate career, but had to sort of take a step back because her workplace would not understand what she's going through, and I feel like that's not okay. Like it cannot be okay at this point when we are having conversations, but we're not willing to accept the same conversations when it comes to workplaces and how the culture there is.
I think these just actually put in very good words the complexity of the challenge, but also the urgency with which we need to move now to address this intersection of MH and SRH. Before we move to questions from the audience, and I'll ask Ankita to give me 2 minutes for that, a final question for our panelists is, based on today's discussions and what you heard from panel number 1, and just generally from your own experiences, where do you see the biggest gaps and therefore the biggest opportunities for menstrual health to work within the larger development sector over the next decade? Big question, I know, but because of time, if you could share this in 5 sentences, this would be great. Dr. Surbhi, would you like to start? क्योंकि आप ऐसे कर रहे थे इसीलिए।
नहीं, मैं वो सवाल सुनते सुनते ना बह जाती हूँ कि इतना लंबा क्वेश्चन में कहाँ पकड़ना है इसको।
सकती हूँ। आपको क्या लगता है कि अगले 10 साल में किस चीज़ पे हम सबको काम करना चाहिए to improve menstrual health?
मुझे लगता है एजुकेशन, जैसे अभी एक नया जो चल रहा है स्कूल हेल्थ एंड वेलनेस प्रोग्राम, जहाँ एजुकेशन और हेल्थ साथ में आ सकते हैं, जहाँ पे जैसे अभी मैं देख रही हूँ कि पहले वाले जो हम उसमें पैनल में बैठे थे तो वहाँ सेक्सुअल एंड रिप्रोडक्टिव हेल्थ की बात हो रही थी, अभी हम सिर्फ मेंस्ट्रुअल हेल्थ पे बात कर रहे हैं, और मुझे वो ज़्यादा अच्छा लग रहा था कि हम मेंस्ट्रुअल हेल्थ को बिल्कुल आइसोलेट लेक करके नहीं चल रहे थे, सेक्सुअल एंड रिप्रोडक्टिव हेल्थ साथ में चले, कॉम्प्रिहेंसिव जो सेक्स एंड सेक्सुअलिटी एजुकेशन है वो साथ में चले। ये जो 3 लेटर वर्ड है ना, सेक्स, ये हमें डराना बंद कर दे, इस पे हम बात कर पाएँ, क्योंकि हम अभी भी जब भी इस पे बात करते हैं तो लोगों को लगता है पता नहीं हम सेक्स करना सिखाने वाले हैं अपने बच्चों को, पता नहीं कितना ही बिगाड़ देंगे। तो सेक्स मतलब उसको एक ही तरह से ग्रैस्प किया जाता है। तो नॉर्मली जो मैं अपनी साथ में स्टोरीज़ जो सुनाती हूँ और अपने एनेक्डोट सुनाती हूँ कि अगर बच्चे की डायरी में भी लिखा है ना, नेम की जगह नेम लिख दिया, एज की जगह पापा इसमें क्या लिखना है नीचे, यहाँ पे सेक्स लिखा है, तो वो लड़ने बैठ जाएंगे किसने सिखाया इसको। वो सवाल समझने से पहले वो डराने लगता है, वो जो 3 लेटर वर्ड है। तो जैसे सर ने भी बोला कि इसको किसी तरह नॉर्मलाइज किया जाए, समझा जाए कि हम बात क्या करना चाहते हैं। अभी शायद हम जब सेक्सुअल एंड रिप्रोडक्टिव हेल्थ की बात करते हैं तो शायद हम वहाँ पहुँच ही नहीं पाते जो हम कहना चाहते हैं, और जहाँ वो रुक जाता है सामने वाला जो माइंड है। तो इसको कॉम्प्रिहेंसिव उसमें लेके चलना, जो सभी लोग अभी तब से बोल रहे हैं, मुझे बहुत ही अच्छा लगता है कि हम पंचायती राज की बात करते तो हम पंचायतों तक भी पहुँचे, हम स्कूल की बात करते तो स्कूलों तक भी पहुँचे, अगर हम ANM, आशा वर्कर, सखी, सथिनी, इतने सारे तरह के ग्रुप्स बने हुए हैं अलग अलग जगहों पे, और हर गवर्नमेंट कुछ ना कुछ इसमें नया करने का सोच रही है। बट प्रॉब्लम क्या होती है कि पुराना डिलीट नहीं करते, उसको डिजिटलाइज नहीं कर रहे, वो काम वहीं रहता है और नया काम ऐड होता जाता है। तो वो इवन तो करना चाहते हैं, बट उनके जो टारगेट होते हैं वो बिल्कुल अलग तरह से उनको लेके जा रहे हैं कि आपको जनगणना करनी है। अब वो कैसे स्कूल में बैठ के उसको 1 घंटे के लिए बोला जाए कि आपका ट्यूसडे को आपको बच्चों को मेंस्ट्रुअल हेल्थ पे भी पढ़ाना है, MHM रूम भी बनाना है, क्योंकि उसके लिए फंड भी नहीं है। तो ये जब सारी चीज़ें अलग अलग जगह पे अलग अलग तरह से जो हो रहा है ना, इसको कंबाइन करा जाए, और मेरे ख्याल से तब से हम सब लोग इसी बात को ये कर रहे हैं कि इसको एक कॉम्प्रिहेंसिव रोल देने की ज़रूरत है कि कैसे, स्टेप्स क्या है। हम बस बोलते हैं करना है, इसका एक प्रॉपर डॉक्यूमेंटेशन होना चाहिए कि लेवल 1 या जहाँ जितना गैप है वहाँ कहाँ से शुरू करेंगे, वो गैप आइडेंटिफाई हो, उस गैप को भरने की पूरी वो हो कि अब MHM रूम तो बनना है, लेकिन उस रूम का होगा क्या। हम DM के पास गए, हमने कहा कि मैम हमें ना रूम के लिए ये सामान चाहिए और ये करना चाहिए। कहती हैं कि स्कूलों में और बहुत कुछ हो रहा है, मैं आपको बेड तो नहीं दे सकती कम से कम स्कूल में लगाने के लिए। उनका अपना एक चैलेंज है, उनकी लाइफ के अपने बहुत सारे चैलेंज। तो आप कहीं भी वो गैप, जैसे अभी इसने बहुत अच्छे से कहा कि हर चीज़ को थोपा नहीं जा सकता, गैप समझना, उस पर्टिकुलर गैप में क्या स्टेप्स होने चाहिए, उसके कुछ मुझे लगता है कि हम सबको मिलके कुछ डॉक्यूमेंट करना चाहिए कि हर जो नया आने वाला है उसको फिर मतलब रीइन्वेंशन ऑफ व्हील ना करना पड़े, उसे पता हो कि ये गैप है, इसके लिए मतलब यूट्यूब पे मटेरियल अवेलेबल है, ये आईसी मटेरियल अवेलेबल है, किसने क्या क्या कर लिया है वो एक जगह हो, ताकि हम सब उसको नए आने वाले लोग भी हमारी चीज़ों को यूज़ कर पाएँ और उसको जल्दी भर पाएँ उस गैप को। आई थिंक
जैसे कि मैंने थोड़ी देर पहले भी बात की थी कि इंटीग्रेशन सिस्टम में इंटीग्रेट किया जाए, ताकि जो हमारे एग्जिस्टिंग स्ट्रक्चर हैं, वेदर इट इज़ ऑफ हेल्थ और न्यूट्रिशन, वहाँ पे जो टच पॉइंट्स हैं उनमें काम करने की ज़रूरत है। चाहे गवर्नमेंट है, चाहे सिविल सोसाइटी ऑर्गेनाइजेशन है, हम आप लोग हैं। दूसरी बात जो मुझे लगती है वो ज़रूरत है कम्युनिटी ओनरशिप की। इट इज़ वेरी मच इम्पॉर्टेंट। उसके लिए हमें इंगेज करना होगा। जैसे हम थोड़ी देर पहले बात कर रहे थे, मैम ने भी बात की थी कि जो सोशल नॉर्म्स हैं बहुत डीपली रूटेड हैं, उनको समझना। और क्योंकि ये जो सोशल नॉर्म्स हैं वो फैमिली, स्कूल्स, कम्युनिटी सबसे होके गुजरते हैं, और ये हमारे जो आइडिया है मेंस्ट्रुअल हेल्थ का, या जो हाइजीन कैसा रहना चाहिए, कैसे होना चाहिए, या फिर जो अडोलेसेंट गर्ल्स या वुमेन जो चीज़ को हाइड भी करती हैं, ये जो टैबूज़ हैं, जो स्टिग्मास हैं, मिथ्स हैं, उनको समझने की ज़रूरत है। और उसके लिए हमें डेफिनेटली इंगेज करना पड़ेगा हमारे फ्रॉम वेरी बिगनिंग, कि पेरेंट्स, फादर्स, मदर्स, सन, डॉटर, सिस्टर, सेल्फ हेल्प ग्रुप्स, कम्युनिटी इन्फ्लुएंसर्स, कम्युनिटी लीडर्स, उन्हें हमें इन्वॉल्व करना होगा। और तभी हम जो ये हार्मफुल नॉर्म्स हैं, जो रेस्ट्रिक्टिव नॉर्म्स हैं अराउंड मेंस्ट्रुअल हेल्थ को कहीं तक, किसी हद तक हम पहुंच पाएंगे, जो कि मुझे ऐसा फील होता है। और दूसरा, जब हम सिस्टम इंटीग्रेशन की बात करते हैं, तो आज के टाइम पे, जैसे आज हमने काफ़ी सीखा, काफ़ी जाना कि इट इज़ वेरी इंपॉर्टेंट टू अंडरस्टैंड कि ये हमारी लाइफ की हर स्टेज को अफेक्ट करता है, चाहे वो लाइवलीहुड है, न्यूट्रिशन है, एजुकेशन है। तो इन चीज़ों को साथ में लेके चलना, हमेशा इसकी अंडरस्टैंडिंग साथ में लेके चलना, अलॉन्ग विद द कम्युनिटी ओनरशिप। क्योंकि प्रोग्राम्स आते हैं 5 साल के लिए, 10 साल के लिए, दे हैव देयर टाइमलाइंस, उनके ऑब्जेक्टिव्स हैं। एनजीओ को जाना होता है, गवर्नमेंट को दूसरी तरफ अपनी अटेंशन देनी होती है। तो इट इज़ वेरी मच इम्पॉर्टेंट कि जो कम्युनिटी ओनरशिप हो उसको लेके। और रही बात इंफ्रास्ट्रक्चर की, डेफिनेटली वी आर डूइंग वेल, एंड इट इज़ वेरी मच इम्पॉर्टेंट कि इंफ्रास्ट्रक्चर होना चाहिए, प्रोडक्ट्स होने चाहिए, सर्विसेज होनी चाहिए, बट it is also important to understand the social norms behind it.
I don't think I'll be able to stick to 5 sentences. But I'm going to use the most overused word, 10-year expectation, which is intersectionality. But I'll tell you what I exactly mean. Just yesterday, I was at a workshop on climate disasters. And it had 16 organizations, 16 organizations who are working on disasters across the country. For decades, not a single word was mentioned about the impact of a disaster on the SRH and menstrual health and health access for young women, etc., etc. I think menstruation, sexual and reproductive health needs to be a conversation wherever any conversation is happening. Be it on education, be it on health, be it on livelihood, be it on future of AI, be it on climate change, be it on anything whatsoever. It has to be that integrated, is my imagination. I would like to contribute to it, right? I feel we need to think beyond the usual. We don't need a film like Padman, or whatever it was called, Padman, I think, yeah, to mainstream the dialogue. We need that conversation to be happening in every OTT show like it's a normal thing. You know, there's a very popular series called Anupama. Some of you might know about it. Very casually talked about why bursting crackers in Delhi during pollution is a bad idea. Very casually. And then, went about their own conversation. It became an example of how narrative change is done in climate change. We would like to see something like that. Like that it's so normal that in any other movie, if there is a lead character who's having her or their periods, is able to talk about it in just general context like it's not a problem. In regional language, even better. Why is it not a part of local, folk culture? Why can't we make it a part of local emerging folk culture, not traditional folk culture? But there is so much regional language hip hop that is coming out on local issues. Can it not become a part of that? So I think that normalization of menstrual health, sexual and reproductive health across multiple issues, across where we're accessing information, is, for me, from where I sit, would be the ideal outcome in the next 5 to 10 years.
So, can you repeat the question? So, when we design a program, we give a lot of knowledge and awareness, but there is a very limited scope of practicing it. So, a lot of organization talking about multiple availability of product, we also do. We do not enforce any one type of product कि हमारे यहाँ पे ये अच्छा होगा and all. Most of us are demonstrating different type of product, but not a single one is accessible in a community. Okay, there is a large dependency on freely available or given products which are largely single use pad. So that's a gap. So when we are talking about awareness, we are not putting much effort on accessibility part. So there are various organizations are trying to set up pad production unit, self-stitch module and all, but it's a very limited efforts gone. So that is there. Another gap was, I will say was, and because there is a scope, there is no interlinkage between education, nutrition, health, for menstrual health education in the institutions. There are programs in RKSK, there are modules of RKSK, schools supposed to do something for menstruation. Every department has something written in a very limited scope. Because this Supreme Court judgment, governments have shown keen interest in doing something. Now there is a competition between states, so you can take that opportunity where you can bring multiple departments together and guide them if really require. You can help them budgeting different element for somebody do a major role of awareness, somebody plays part in product development or accessibility, somebody thinks about disposal, like water and sanitation department. So currently, because government is kind of keen towards putting efforts on menstrual health, this is a very good opportunity and you can try to bridge this gap.
Lovely, thank you. I think some keywords that stood out to me was being comprehensive, having a collaborative attitude, document your work so that others in the sector can also learn from you, have intergenerational conversations, create community ownership, involve everyone from start to finish, create intersectional programs, destigmatize, make things accessible, contextualize, and my last favorite word of this conversation was choice. Enable people to have that choice. Unfortunately, I don't think we have time. Lovely. We can take one question from the audience if we have any.
Sorry, this is not a question, but just an input. I'm Pranita Biswasi from YWC of India. I think while we are talking about what we really need to do, one thing which we might have to also focus is about the narratives, replacing the narratives and language. Because if by chance some of us has a period stain, the first thing which we say to the others is sorry. That's where we feel like it's an embarrassment and we say it to others. That's one thing. And the other thing is about also shifting power, where we were talking about community ownership and all. So how do we give the power to who is benefiting, who is setting the agenda, who is planning for it, who defines the how and what? I think in these areas, if we focus more, and the intersectionality which was posed out, I think that's where we need to build different target audiences and timelines. Thank you.
Thank you, Pranita. On that wonderful note where we have even more questions to answer, I think we'll close panel number 2 for today. Thank you so much, panelists. I know you've given us a lot of food for thought, and thank you for being patient with my questions. Just a small token of appreciation from all of us at Bala. Thank you, Vaishnavi. Thank you so much, panelists. I'm going to hand over now to Subhajit from the Founder's Office back to close us off for the first half of the convening.
Good day, panelists, moderators, catalytic partners like QRG Foundation, Young Fiki Ladies Organization, and Accelerate India Philanthropy, our knowledge partners, YWC of India and YLAC, and definitely the Bala team, for bringing such depth, such honesty, as well as a lot of energy in today's conversation. Thank you everyone for your questions, for your patience, as well as your reflections, and for staying engaged throughout the discussion. A special thank you to India International Center as well as Shanti Art International for the space and the collaterals. So we today came in asking why menstrual health is still the missing indicator in SRHR frameworks. We leave with sharper questions, shared learning, and practical ideas that we can take forward. We will now break for tea and coffee and then rejoin for the learning sessions. All participants who were offered the opportunity to be part of the closed door learning sessions are requested to be back here by 5:55, and we will start sharp at 6. And all the participants who were part of this event, irrespective of whether they are part of the learning sessions, will receive all the findings that we collaboratively collected today via email. On behalf of the entire Bala team, I wholeheartedly thank you that you gave us your time as well as your thoughts. I am Subhojit. It has been a privilege to learn from this room today. Thank you so much.
On the learning session agenda. If you still have some confusion, please reach out to Soumya Singh. Soumya Singh, please raise your hand.
बैंगलोर के अलावा भी दुनिया में देश बहुत बड़ा है अच्छी करोड़ औरतें हैं नहीं सिमटा हुआ we are trying to understand where this space is. Sorry for this awkward silence.
And take a and we asked the students to just put their thumb on a
Challenges, we've explored gaps, we've asked slightly difficult questions, and this next session is about moving from discussion to action. The purpose of this learning session is to collectively think through solutions to some of the most pressing challenges when we're talking about integrating menstrual health into SRHR systems. So rather than focusing on what is missing, we'll spend the next segment asking what can be done, what should be prioritized, and what should realistic, actionable solutions actually look like. The ideas generated today will help inform future conversations around policy, program design, service delivery, advocacy, and system strengthening. To guide this process, we have 3 really cool tables and some really cool facilitators representing 3 important perspectives that emerged throughout today's discussions. Joining us from YLAC, or Young Leaders for Active Citizenship, are Himani and Natasha, if you'd like to woo! Himani and Natasha bring perspectives on youth engagement, public policy, digital governance, and translating ideas into meaningful advocacy and systems change. Representing YWCA of India are Pranita and Angela, who bring deep experience in youth leadership, gender justice, inclusion, community engagement, and will help ground our conversations in evidence, research, implementation realities, and lived experiences from the field. Together, our facilitators represent the kind of cross-sector collaboration that menstrual health actually requires. With that, I'm going to hand it over to our facilitators who will introduce the problem statements and guide us through today's solution sprint. I will do a quick check-in around 6:45 for time, and we'll be breaking for tea at 6:50, after which at 7:15 we're going to come back for table presentations. Good luck, everyone.
Just imagine what is missing in terms of this integration of There's actually a project run by YWCA and related to SRHR and I'm from
Hi everyone, this is Vipul. I associate with Asmita Kirati, but recently I started now on menstrual. So we are using digital tools for social engagement. So we do advocacy on capacity building tools.
Okay, great. So I'll just set some context on what we're trying to do. Essentially, it was just with the Bala had just like a webinar there. Action sort of right. We all understand the menstrual health as a topic has certain visibility, but even then, the context in which it's used is limited. We talk about hygiene, we talk about access to products, we talk about menstrual health as a rights-based framework, right? How does it interact with, say, education? Or how does it interact with healthcare? Or how does it interact with people protection or social economics? We will consider menstrual health as like an ideal employer framework. What kind of behavior changes do you see when there are programs that integrate menstrual health to larger fields of race, justice, again, there is a small problem on the sheet which will help to sort of explore what it is that you want to do. Moving on to the next sheet. So we have narrowed it down slightly. Yes, where does program fit, right? So the most important thing that is coming up again in conversations is do we have enough funding? Is there misalignment between these objectives? What is it that is leading to programs not being successful in the way that we want them to? Or what is it that is preventing this sort of integration, so to say, like are we different silos and what is that silo that activity like? Simple example, you are taking for communications, how would that there are campaigns, how would this be? Or imagine working in Sulabh, so how is that? Because washing structure and the way that we work on again, very silo. Chiranshu, you are working specifically with pads. So how would that take you beyond product and make it more largely what you do via again, there's a prompt to help you sort of kickstart where you want to change. And I think the final thing which is key for us is what makes programs guys. So I think one thing that there was so much focus on being a women's issue that I felt like there was not enough focus on gender issue for menstrual, right? So again, that's a breaking point in our program. So how do we make our programs more inclusive from all aspects of the So I'm going to give you 15 minutes of time for each table. Each table has a timekeeper and a person who's also going to help you with any kind of, and these 15 minutes would then rapidly score chapters and then you will move on. Yes. Okay, a minute and a half more. Sorry.
We'll go one by one thing at a time, and we'll spend around 3 or 4 minutes brainstorming on
So we could actually just give me 1 second. You guys share
Rather than women. Yeah, not every menstruator is a woman and not.
So
People who don't identify as women.
So
individuals
menstruating
community is
menstruating individuals and bracket में आप लिख दो मतलब beyond women and gender wise.
You can clear the table and then spread out the pieces on the table.
ये आपका वाला तो यही है
Not because that's more YWC now. So.
ये एक्चुअली वहीं से आ गया ये
I think one is not this related.
one person is missing actually. We are three only.
She's from Dubai.
We are three.
Please go through the problem statement. Now, some resources. We'll have to find answers to those questions through those resources, or if you have any other thing, we have sticky notes we can put out.
You can brainstorm and come up with solutions. Educational spaces. Have chapters around each other. Access to products is another.
To describe scientific concepts of any kind. Yeah. So PWD is entire spectrum.
I think this is a very good responsibility. Having postpartum dialogue is essential. More dialogue.
expecting that we will enable dialogue to happen.
Workplace policies is one thing. When we're looking at labor and social protection, so we say that there are regulations that mandate security have certain products available, or like you said, all kinds of workspaces. There are washrooms with facilities available, there are restrooms available. Those will be regulations at a systems level. So
Except policy as an example. We know that India does not have a recognized menstrual policy, right? But we have certain states sort of passing new policy for their state government, and in some cases, for example, Karnataka is also recognized and extended to private players. right? But then if you work
Resources are here. Pick up the resources as you need. Resources are here.
जिसके दिमाग में जो है आप लोग बोलो.
So मुझे for me education plays a very important role in this thing. Educate कर दिया जाए. So it will take more impact. अगर education वाले level पे इसको normalize कर दिया जाए, सारी चीज़ें easy हो सकती हैं. जैसे example that is my
हमारी टीम सबसे आगे
Okay, menstruation not recognized as legal as part of policy.
इसी का सब है, इसी का सब.
It's not even a list of women
Down
well
to
being.
And because of
I'm writing men's mainstreaming.
So we have to break the programming into words.
Mainstreaming and implementation.
Too many trial projects.
So there should be an integrated approach towards funding and funding. And besides that, like I know Pharmacy pointed out, everybody is just giving tags. Nobody is talking about what happens.
Exactly. Even the system, like a big picture, just one
Big
outcome.
प्रिविलेज है, बट उनमें वो प्रिविलेज नहीं है कि वो बैठ के डिस्कस करें. बट अगर दोनों सेम मतलब राइट नाउ मैं किसी को समझा रही हूँ, अगर मैं किसी को बोलती हूँ कि पीरियड्स ऐसे होते हैं, बट आई एम वेरी प्रिविलेज बैकग्राउंड, बट आई एम कंपेयर, और मैं अगर कोई स्लम में जाके देती हूँ, आई एम कंपेयरिंग एप्पल्स टू ऑरेंजेस, राइट. बट अगर मुझे चाहिए होगा कि ऑरेंजेस ही बात करें, तो मे बी आपस में हम लोग अभी आपस में बात करें, बिकॉज वी आर समवेयर फ्रॉम द सिमिलर प्लेटफॉर्म. हम लोग सब आपसी एक साथ अगर विलेज लेवल में या जिस कम्युनिटी में भी जा रहे हैं, वेदर इट इज़ मैन, वेदर इट इज़ बॉयज़, वेदर इट इज़ जो भी है, तो वो आपस में बात करें. दी अंडर प्रिविलेज, या फिर इफ देयर इज़ अ फिजिकल डिसेबिलिटी, अगर किसी को जैसे ब्लाइंडनेस हो, किसी को डेफनेस हो, तो सारे मतलब उस एरिया के अगर देयर आर सम डेफ चिल्ड्रन टुगेदर, नॉट ओनली फ्रॉम द स्कूल या कहीं से सारे एक साथ मिल के सिमिलर ग्रुप्स में अगर वैसे करके डिस्कशन, दैट विल ऑल्सो, लाइक दे सेड अर्लियर इन द अंशुल आई थिंक पॉइंटेड आउट कि लिसनिंग इज मोर इम्पॉर्टेंट दैन स्ट्राइकिंग, कि मेरे हिसाब से तो ये सही है.
OTP शेयर मत करना.
वो मेरा सर्विसिंग का था.
जल्दबाजी में ट्रस्ट में ऐसे ही होता है. मैं खुद बचा हूँ,
अभी तक कोई भी
मैं इतना ज़्यादा करने के बाद आई ऑल्सो ऐसे ही जल्दी में.
एज ग्रुप में भी ना.
Speaking on behalf of disabled, so she's saying the first question that she has mentioned. Make sure one questions one way every said. Second, captions in different formats.
वो community driven talking, the similar conversation. Yeah, so apples and oranges लिख दूँ मैं. you looking at influencers and all is like a good point. That's a good way to look at it, like the content creators that you're looking at. That's like an easy, palatable way of consuming content that people usually don't think about. If anything conveyed as like a skit or like as a humor always catches people better than like a serious conversation.
Conversations surrounding periods can be combined with
content creation in itself is not you have so many good social media, but it is still that like even online bullying is accepted that conversation there was something on
Then we try to discuss 2 points about what is needed. You all know what are the points. This group has decided who is presenting. Yes. No. So
can we start?
When everyone comes in. So let's take 1 minute each from each table to describe your answers. Very short time, but 1 minute.
Yes, come on.
Yes.
अरे ये ऐसी लगाया है.
Okay, so the
can we see the chart picture?
Reconvene 7:15 sharp. Thank you, everyone.
Can we take the 5 minutes?
How can it be systematically integrated? So, very much agreeing with what you just shared about कैसे community में awareness होना चाहिए, deeper sense of awareness होना चाहिए, और जब मेरी community में से कोई मेरी community में वो बात करेंगे या वो उस तरीके के point को आगे रखेंगे, it will become easier for me to then receive it in that space. So, how can that be made a long-term consistent effort, not like एक बार यहाँ पर awareness aware कर सकते हैं तो उनका circle बहुत छोटा होता है, like 5 years. So they are in many ways they are going for all the immunization. So we have to collectively present all that. We need to present everything that we what is the market you're working on, what was the problem. You can decide. Essentially, so we essentially did
Yeah. And all together.
Why? Somebody else has to go.
So good to know that people are working in this space. Facilitators, if you can confirm if your table mates are in the room. While at table, is everyone here from your table? Okay. I hope everyone had a good tea break. We're now moving into the presentation section.
Table focused on adolescents education, integrating menstrual health and SRH, and one table focused on family planning programs, MH and SRH. So the format of the presentation is going to be this. We have two presenters from each, whoever would like to join. Thank you.
Good evening, everyone. We are from Team Bala, and our problem statement is.
So she is Arunima, and I am Chitransh.
Yeah, thank you for introducing me. I'm so focused on presenting, and yeah. So our problem statement is to design an adolescent education program on the basis of the gap identified, behavior change, and the output and integration of MHM and SRH. Okay.
Okay, so for this, our target audience are 14 to 18 years students, those who are like from school leaders, head girls, and head students, and their facilitators and trainers from the schools.
Okay, and the idea is to build a comprehensive education on MHM and SRH, covering the biological aspects, the mental aspects, the social aspects, the environmental aspects, and the idea is to debunk the myths and shift the stigma related to it.
So, or a WhatsApp or a dedicated phone line for resolving their issues.
Yeah, so this is the part of the activity that we will be doing, that is along with conducting sessions and talking about the awareness on mental and social aspects. We will provide one dedicated WhatsApp or telecalling line where one-on-one they can have discussion.
We have targeted CSR, corporate body funding,
So weekly and monthly status of uptake of hygienic products. And last will be the log frame preparation. Based on that, we will keep an eye on our development of the program. Thank you so much.
WhatsApp and helpline helps like that. Like people are searching on internet and on AI, on chatbots. So like many informations are flooded over there. So it's very hard to select which information is correct or not. So for WhatsApp helpline or for helpline, a doctor or an expert can guide a better from the AI or information available on the normal internet. Yeah, that's all. Thank you.
So from Team Bala, we're Team 2. So our main agenda while creating this family planning and reproductive health program for specifically, like I'll go through each and every sort of age range and everything that we talked about, but before that I'm going to talk about a bit about what our aim was. The aim was to ensure the women or the individual who's going to be pregnant has contraceptive choices. She is targeting, we've narrowed it down to 3 different age ranges, because we all know that despite, of course, women not being of the legal age to marry, girls still do end up marrying fairly early. So the first age range is between 16 to 20 of giving the resources. We'd want the ASHA workers, PHCs, NGOs to take role in this, because they'll be the ones, and Anganwadi workers, because they'll be the ones who will be having access to all these 3 different types of family. Chatbot is going to be there for me to sort of directly answer these questions. Then local teams will be assigned for these chatbots to ensure that they're working well and then answering the questions correctly. So there needs to be localized information.
Hi everybody. First off, I don't know how you all did so much in 40-45 minutes or have to follow. But we'll still tell you everything that we did in our group. We were looking at developing advocacy strategies for integrating menstrual health in the broader SRHR framework. So what we did was we looked at advocacy as a roadmap. The roadmap that we built to achieve a certain specific shift, be it in norms, be it in policy, be it in programs. What we ended up doing was dividing the group for an exercise where we focused on 3 broad themes of education, healthcare, and labor and social protection. And everybody worked backwards. So we didn't start from problem statements, we started from goal setting. What is the outcome of my advocacy that I envision? What is my success statement? And then we work backwards. We looked at 5 broad things, identifying existing gaps and hooks, looking at who my champions are, looking at the proof of concept that exists, looking at the resistance that I might face, and then thinking of what my immediate next step or milestone might be.
Hi everybody, I am Urshita, and as Mani said, I am representing the education part of it. So the end goal that me and my partner Chinmay envisioned was that my teacher understands my situation, that I am having my period, and he empathizes with me. And my period pain is not a stigma, and I'm not shying away from it or fearing it, and it is not considered a weakness. Taking rest or taking a medicine for it is not considered a weakness. So while moving backward, we decided what were the gaps or hooks where we were lacking is educating adolescent boys. So we get education campaigns, and we just basically create a community that helps men involved in the conversation. Thank you.
Good evening, I'm Anuja, and we talked about the healthcare part of it. So the idea that we initially came up with was eco-friendly or biodegradable pads cost 1 rupee, therefore making them accessible to rural India, that is pad for all. Turns out something like this already exists, and it exists under the name of PM Bharatiya Jan Aushadhi Pariyojana, which we had no clue about, even though we are the ones working on field, and it was already covered. Proof of concept also covered, because this scheme exists, but it is not as aware. We are not aware of that. The risks, when we tried to delve into the risks, what we figured that if something like this exists, why do we, the policy makers, the young leaders, the founders and so on, are not aware of this? Probably because there is no awareness about it. There's a lack of legitimate distribution. They can be one of the quality check markers there, and maybe somebody from the private sector also, maybe someone from the NGOs. There are so many ways we can partner with the government to be doing it. Probably for the quality check, so they are not bleached, they are eco-friendly, they are not causing rashes and so on, right? And then comes the awareness part of it. For awareness, we have either gatherings, or mostly for the elders, we can target them to just have a note written that these pads are available, so you can go and get it from there. And this is what the roadmap also includes, having more people a part of the conversation, making more people aware.
Much time, because most of our time went by doing with brainstorming and all. So I and my partner Chuma, we both came up with this particular output regarding menstrual leave, which is menstrual health and hygiene is already recognized by the Indian government as a right. And there are states like Odisha, menstrual health policy is there, and we have Bihar government implementing menstrual leave policy in school, and recently we have Kerala government implementing. But yes, few of the risks when we are talking about menstrual leave, while we are reading while we are reading literature and also coming across certain discussion, is it will increase discrimination, and women will not get job and all of that. So so we could not prepare a roadmap, but we have to think about how to
Adding a bit of the industry perspective, realize that while we might put these mechanisms in place, but I mean, through our conversations, we realized that the lowest hanging fruit in terms of implementing even the lowest hanging fruit is very tough over here. But the idea would be, if we were to go for your bigger legacy brands, say your Tata Steels and the Godrejs of the world, who have the capacity to implement these mechanisms, at the same point of time, who face some amount of pressure to conglomerates, and then sort of puts pressure on the intermediaries. I don't think realistically the smaller companies can afford to take up something like this at the moment, but willing to have that conversation post this.
Hi everyone, good evening. We are the last ones, we are the YWC of India table. Okay, the last ones come with the pressure, right? You have to end it soon, yaar kab khatam hoga. Exactly the same way which we think about our pre and post menstruation ki kab khatam hoga the effects. Yeah, so we had a reiteration in our table actually, like menstruation is not just limited to menstrual health is not just limited to menstrual hygiene is not just limited to sanitary napkins and sustainable products, and also not limited to incinerators, but also fundamentally through violence, through different discrimination, how it is ingrained. That's how we saw in our table. The main, what we followed as a facilitation is like we identified a problem statement. We took this as a community. So we are focusing more on expert, less on expert and more on experience based. So that's how two groups, one on the socio-cultural practices and menstrual health. Do you want to please come in?
Yes. I just wanted to say bye to everyone. I have to catch a flight and leave. But so everyone for sharing your perspective, for being interested in the work around women's health, be it menstrual health specifically, or all of the allied topics that have an a really special shout out to all of our partners today, YLAC, YWAC, for being here with us and helping us, bring these insights out. And I really wanted to bring a big round of applause to the Bala team. Soumya, Subhajit, Navratan, all of our volunteers here today helping us out. Thank you so much. And we really, really want us all to be connected. If there's any way we can partner, any way you think one of the intersections makes sense to the work that you are doing, please reach out. It may not happen right now, but it will be good to be together and try to do this work together. So thank you again, and I hope you enjoy the last two presentations. I'm going to get an update from everyone on how it goes. So thank you very much.
Is there a mic there? Yeah. Is that working?
Hi, good evening everyone. Again, a big thank you to Team Bala and also a big congratulations for having us here. And a big thank you to even Angela and Pranita for helping us put together. And our team members are Vipul and Sanjana, and I'm Dr. Ankita. So basically our topic is around that why are there gaps that are existing, the current practices, the taboos around menstruation, and how can we bring about a change or what can we do around it. So addressing the very first issue, that is why there is a problem. So what we figured out in our discussion was that, like we put it here, I love my comfort space. So what we mean by that is there are a lot of tabletop discussions which happen. For example, if we take even the discussion that we've had today or the event which is here being conducted, there are very few people who have actually gone down to the ground level and done some work when it comes to raising awareness or even to distribute pads or to work around the menstrual hygiene aspect. So we do have a lot of discussion. They love their comfort space. They love the privilege that they come from. So going from privilege to underprivileges, that is something, the gap. A lot of grandmoms or the mother-in-law that we were talking about, that's why the snake makes sense, the vamps, how we put it out in the television media industry, okay? So we would need more of their support, to be very honest, right? So in the sense that I still remember one of my sister's friends, she had gotten her periods in the middle of the night. And there's a ritual where you're supposed to get up and take a shower the moment you get your periods. So because her grandmom will be raising an issue with that, so she did not tell her grandmom that she got her periods in the middle of the night. So she got up in the morning, like one small chapter or just one small, concept. But we wanted to be a part of the entire curriculum where it is treated right from menarche to menopause. There has to be a more elaborate curriculum at the policy level, at the curricular level, which has to exist. So this is the entire thing that we've tried to work around. So yeah, thank you.
अभी बहुत लोगों ने बात करी कि स्कूल्स में गर्ल्स के साथ बॉयज़ को भी ऐड करना चाहिए, सारे स्टूडेंट्स को एक ही क्लासरूम में इस चीज़ पे बात करें, मेंस्ट्रुअल या सेक्सुअल और रिप्रोडक्टिव हेल्थ राइट्स के बारे में. बट हमें कम्युनिटीज़ में भी एक ऐसा स्पेस बनाना चाहिए जहाँ पे इस बारे में बात हो. बात ऐसा ना हो कि हम उन्हें बताएं कि क्या चीज़ करनी है नहीं करनी है, वो लोग खुद बताएं कि उनके घर में या फिर किस चीज़ को लेकर वो क्या चैलेंजेस फेस कर रहे हैं. अगर उनकी मम्मी कह रही है कि अचार नहीं छूना है तो वो खुद बताएं, और उस पर हमें क्या करना है, बस उनमें एक लाइक अ स्पार्क या क्वेश्चन करना है कि ताकि वो खुद से क्वेश्चन करें, ताकि वो अपने घर पे क्वेश्चन करें, तब जाके शायद थोड़ा सा रिजॉल्व हो सके, वो खुद के लिए स्टैंड ले पाएंगे. क्योंकि हम किसी के घर पे जाके सब में चेंजेस नहीं ला सकते, या फिर हम कहें कि हम सिर्फ स्कूल में अवेयरनेस फैलाने से, स्कूल में स्टूडेंट्स या एडोलेसेंट्स के साथ सिर्फ वर्क करने से आई थिंक नहीं होगा. क्योंकि बच्चे जो बड़े होते हैं तो उन्हें जो मम्मी ने सिखाया होता है वो देख के या सुन के, तो हमें उन पे भी ज़्यादा वर्क करना चाहिए.
I'm sorry, I'm just taking one last part. We forgot to mention one point is why there is an issue is because we've also not included the trans men who menstruate. So in the entire panel discussions or whatever you had since evening today, there was no discussion where we mentioned that there is a trans men or menstruators. We use the word women and girls always. So I think there is also a gap which is existing. We need to address that there are trans men out there who are also menstruating and who are having issues with it. So yeah.
Where I can move around.
I don't know, there will be a green light which will be turned on.
Okay.
Can you hear me?
Yeah.
Okay.
So she is Bhavi.
Hi, I am Bhavi.
On ground, in school, in communities as a menstrual health facilitator, and I'm also a nutritionist. I work with so many NGOs and all, and I know the ground reality, what it is among the communities as well with the school children and adolescents.
Yes, so yeah, we've explored actually how climate justice and menstrual health intersect with each other, and it's been quite an interesting conversation. So there have been, like ma'am said, but in a lot more deeper sense, कि कैसे एक A&M के लिए भी क्या reality है और एक community member जो शायद उनसे distant है, उनके लिए भी किस तरीके की realities exist करती हैं, and how can that be taken into add one more point to it, which is also about deepening that in the awareness, talking about aging from various mental disabilities as well. So taking all of those things into account, climate financing needs to be more gender responsive. Climate finances that is something that needs to be taken into account. Representation is something that we were really keen on. We said that it affects, climate affects, that was the other thing. One concluding point about, because we also spoke about disaster preparedness and how can that be made more inclusive. It requires trained interpreters in spaces. We cannot have short-term mitigation practices. We need more long-term solutions, as well as not one standard solution that fits all, right? Basic needs से आगे बढ़कर हमें सोचना पड़ेगा, and we need to talk about how can these things take gender into account and the experiences of the people. So yeah, that's all.
Since we are talking about climate, so we know there are so many menstrual products that are available, like tampons and pads and menstrual cups. So if we are talking about that, then menstrual cup comes to our mind first of all, that it will not increase that load. But with menstrual cup also comes the hygiene part. So wash has to be included, because we need clean toilets, clean water, potable water. So there are so many issues that needs to be addressed when we are talking about climate. Climate and season affect menstrual cycle also, because sometimes it gets lengthened, the flow, family, their belief system. Because I remember when I got my first period, I was handed a pad along with a list of instructions. That is how my period started. Because my mother gave me a pad, go and use it, don't tell your father, don't come out. There were so many restrictions. But that way, we are happy that now we can talk about it. अभी 3-4 साल पहले तक भी जब हम पैड्स लेके आते थे तो वो या तो पेपर में रैप्ड होते थे या ब्लैक पेपर में होते थे. Now at least we can blink it. So that is very important. तो जब बात हम इसकी करते हैं तो wherever we go, if we are talking to a 9-year-old girl, whether we are talking to boys, it should be in that tone where they can understand it and it's not repulsive. You have to understand that there's social conditioning as well. Because in India, there are a lot of stigma, lot of taboos, but one by one, I'm sure this room is full of similar thinking people. We can surely address that. So for climate change, and also the menstruators we said, but we forgot about the person with disability. They also face different kinds of stigma. So we should include them also. The visuals, I prefer the content should be visual. So interactive content is important. maybe in braille, so for blind, for people who are deaf, so everything should be included. So that is very important. So R is awareness, inclusion, accessibility and accountability. That is what we want to say. Thank you so much.
One big thing I wanted to add as well, where the oppressed community do the disposal and do the waste segregation. So that also was reflected in one of our discussions. Thank you.
I'm just going to sort of freestyle thanks because I think a lot of the work that we do can sometimes feel a little isolating because we're talking about this sea of work. Because when you're thinking of one intersection you go to, actually it's also linked to this space, to these people, to this demographic, to this geography. Then the work can become a little intimidating and maybe also a little isolating because you're like, am I the only one thinking about this? But I think I personally find in this room just a little bit of, not a little bit, a lot of hope that we're actually, first of all, we're talking about this. Second of all, we have the courage to say, actually, you missed this out. And this is something that we need to talk about, not just in this room, but out there as well. And finally, I think in the beginning when I was saying, okay, we're going to think of practical ideas, but I like the idealism and like the sky is the limit and I'm going to even go beyond in terms of what I actually want to talk about in my learning spaces. So I think all of us deserve a round of applause for our thought process, but also I will say taking note of it. So they will be synthesized and sent to everyone via email over the next few days. Thank you. Our wonderful hymn. Thank you. And I think we can give a shout out, Dr. Ankita, for facilitating all of us.